All right. Is there anybody that does not have a tablet or a computer? You don't have to speak out if you don't want to. You can just send me a private chat. How you do that is go to the chat and then click my name and it goes to me. So if no one says it, no one answers, that means everybody has a tablet or a computer. All right, let me see what's happening. But the person who responded, but do you have one? The person who responded. Let me just type that. As in, do you own one? Okay, that's all that matters. That's all that matters. You own one that you can bring to school. Okay, wonderful. Wonderful. All right. All right, so we'll Kazi, go ahead. If you're speaking, you're muted,
Professor,
Kazi.
I
Go
own
ahead.
one, but right now I can't use that one. Right, right now.
You don't have to use it right now. I'm just saying if you
Okay,
own one.
okay, okay,
All right. Okay, cool.
okay.
So we'll spend 50 minutes doing anatomy and terminology. Hopefully you use those links and looked at the PowerPoints, and then 50 minutes doing positioning, and then 50 minutes with some practice questions. All right. And here's the ART content specification and quiz guide, meaning we will talk about a bunch of stuff, but not everything will be quizzed on, and not everything you need to know for the ART according to the ART content specifications. So I'll try to do this going forward for each procedures section, right? Go ahead, Sarah.
Can you please share this with us now? Or do we have to wait till the end of the class to get this slide?
Uh, I prefer to share it at the end because your questions on here and answers. I don't want people to just try to look at the stuff and give me the answer. All right. And then let me think. All right, you know what? Let me just do it this way. All right, this is now published. It's not on the right procedures, unfortunately, because I don't yet have access to the course. But it's published now on physics. All right. It's not all the content that's on this is on the one that I already uploaded, but it's just a little bit different. All right. So here's what you should know for. Can you see the screen, by the way? Is this on the screen? Awesome. You should
Yes.
know for the quiz. It's going to be in a week and a half from now, and what you should know for the registry. All right, so we're going to PA hand, PA finger, lateral, medial and or lateral oblique, and so on and so forth. All right.
Excuse me, Professor.
Yes.
I just have a question. Are you taking over this class? Like, is this going to be a every week thing or just this week?
We'll talk about this some other time. For now, let's try to get through this material. All I know is that
Okay.
I am here today.
All right. Okay, thanks.
All right, you're welcome. All right. Okay. All right, so some terms that you should know is palmar versus volar and anterior. Palmar refers to, everybody should know this, right? This part of the hand, your palm of the hand, the back or posterior or dorsal. That's going to be the other side. And medial versus lateral. Alex, what's the difference? Medial versus lateral.
Lateral is the side view, like an oblique position.
Not quite, just as far as a directional term. Lee, what do you got for us?
Oh, directional terms. I'm sorry.
That's all right.
Bilateral is opposite, and medial is towards the inside, like towards the middle, and lateral is towards the outside.
Okay, there you go. Proximal versus distal. Let me get Roxanne. What do you got for me?
Proximal is farther away from the point of origin, and distal, excuse me, the opposite. So distal, farther away from your feet, proximal, closest to your head, I believe.
That's one way to say it for sure. Make sure you know this. This is a way to expand on that, right? So proximal just means closer to the point of origin. So for example, this point on your hand is proximal, this point is distal. And if you're speaking of a long bone, then this is the proximal end of this bone, and this is the distal end of that bone. So we should also say that the wrist is proximal to the fingers, and the fingers are distal to the wrist. Is that clear for everyone? Make sure you know it like this, okay? All right, some terminology you should know about different things you will see on requisitions. What the difference between dislocation and subluxation. Here are the definitions on here for you. We won't read from the PowerPoint, but you'll see these on requisitions quite often. And it's important you know the differences between these, right? Because it might impact how you handle the patient and what kind of views you think you should be doing. So the person who orders the requisition or enters the requisition might not always enter them correctly. And you might have to do some kind of supplemental view, depending on what you see or what was requested. All right, so make sure you know the definitions of these trauma terminologies. All right, here's some more for you. I think at least one person is doing, was it Colles fracture? I think, was it Sarah doing Colles fracture? I don't remember. You have some presentation you have to do in front of a board of people. These are actual links, so you can just right click and open it, or just click on it and opens to a link that shows you an image of each of these. Also in the notes part of this, I have definitions of these fractures. All right, so again, you can just click any one of these and it opens up to a link that shows you a picture of what these look like. And there are notes in here that defines all of these. What's a Box's fracture? Let me get Jacqueline. What's a Box's fracture?
Sorry, it's the fifth digit is the pinky.
Got you. That's one. Yeah, sure. That's basically it for sure. Fourth or fifth, by the way. What's let me see. Bennett's fracture. What's a Bennett's fracture, Patricia?
I actually don't know what's a Bennett fracture.
Got you. All right. So make sure you look at these. So you're gonna have to do some. I mean, it's actually not a good use of time to read what these are. The information is here for you. What I'm here to do is to explain some of the other stuff. All right. So again, if you just click these, you will see a picture of what these look like. And there are definitions right under this PowerPoint in the notes part of this. This one's actually pretty important, physeal fracture. This is what I can talk about this one a little bit because you'll see this with kids. So it's a fracture that goes through the growth plate. All right. So if you're working in a place that does pediatric radiography, you might see this a lot. All right, so for the anatomy, pretty straightforward, I think, right? I'm not sure how much you've done before of the hand. I don't think you have done anything on the hand so far, but these are pretty straightforward. So first, you should know that for the hand, we're not doing the wrist, but we're going to talk about the wrist a little bit, just to say that these are called carpal bones. And then just above that, we have metacarpals. And then everything else would be the phalanges.
Professor?
No, yes, go ahead.
Oh, I'm sorry, Professor.
Yeah. So when you see in your textbook or an exam a reference to digits or fingers, they're referring to the phalanges. Just make sure you know this. How many phalanges do you think we have, Raven? How many phalanges do you think we have?
So 4, 6, 8, 10.
I'm sorry. I just woke up. I'm trying to count.
2, 4, 6, 8, 10.
14?
And these are pretty straightforward, right? So
Oh, it's on the slide. I'm sorry. I'm sitting here counting.
that's all right. Just checking if you're paying attention. That's all. So we just talked about, I think it was Alex I asked about directional terms, and we said proximal is closer to the point of origin, and distal is farther away. Which of these, if I should ask you, let me get Angel, if I should ask you to point out the middle phalanx of the first digit. Middle phalanx of the first digit, Angel.
It would be the thumb.
The thumb. Let me see if is it this one? Is it this one? What do you think?
That one.
This one's a middle phalanx?
Yeah.
All right, got you. Trick question. It does not have a middle phalanx. Notice that the digits 2 through 5 have 3 phalanges: proximal, middle, and distal. Digit 1, the first digit, the thumb, only has 2 phalanges, a proximal and a distal. Make sure you know this. All right. So which ones have a middle phalanx? That would be digits 2, 3, 4, and 5. 2 through 5. 2, 3, 5. 2, 3, 4, 5. Digit 1, the thumb, only has 2 phalanges. It does not have a middle phalanx. It has a proximal and a distal. Jeffrey asked a wonderful question through email about the phalanges. They have a head, a body, and so on, and a base. Yes, they do. So Jeffrey, I sent you a link. I didn't want to send this PowerPoint ahead of time, but you can clearly see it labeled here. The phalanges as well as the metacarpals have a base, body, and head. All right. All right, so for this PowerPoint, we'll do wrist next week. You should at least know the anatomy for the metacarpals, the phalanges, be able to point out all of these. All right, so in between, go ahead, Dondre.
Hey, Professor, I didn't know that the sesamoid bone, I didn't know that the fingers also has that. I thought it was just the kneecap.
Yeah, there's
I'm
one here. It's not shown on this image, but there's one right here on the thumb.
How many do we have? It's just only on the thumb?
There's one on the thumb. You got one on your toe also, on your big toe.
Yeah. Oh, okay. So still, all right.
Yeah.
And just the thumb and the toe.
And your patella is a larger sesamoid bone in the body. Do not miss this easy layup registry type question, is the way I have to phrase it legally. Question would be,
Okay.
we'll talk about that later on though. All right, good question. So here we have the bones. Wherever there are bones, there are joints. So when these bones are, how these bones are connected are by joints, and these are pretty straightforward also. So you should know the names of these bones. You also need to know the names of the joints. It's pretty straightforward. So these are well, what are these collectively called again, Elias? What are these collectively called? These bones right here.
No, carpal bones.
Carpal bones. Carpal bones, right? And what are these called here, Avagay?
Metacarpal bones.
Fantastic. So the joint between the carpals and the metacarpals will be the carpometacarpal joint. Pretty straightforward, right? And then so the joint between the metacarpals and the phalanges, you can guess what that is. Metacarpophalangeal joint. And you got most of them down already, right? So that would be 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So if I say to point out to me the third metacarpophalangeal joint, you'll hear that quite often, centering. That will be this one. It will be the metacarpophalangeal joint of the third digit. Right here. And the second one will be this one, and the first will be this one. Pretty straightforward. All right. So then the rest of it is also pretty straightforward, I think. So if the joints are named for the adjacent bones, Well, it stands to reason that these would be interphalangeal joints. Interphalangeal joints. Inter means between, and between the phalanges. And the P part here just means proximal. So go ahead, Alan.
Professor, we have to go upstairs and do our lab proficiency. I thought we had to do class first, then proficiency, but I guess not. So we have to go upstairs and do our chess proficiency.
No worries. This is why I'm recording it.
Okay, thank you.
You're welcome. Right.
Uncle,
I'm sorry. Go ahead. Who's that?
Sorry, Professor. I had to go to the lab too because we got a proficient right now. I thought that it's gonna be in the afternoon, but nobody told us that they're calling us.
No worries. This is why I'm recording it.
Okay, thank you so much.
You're welcome. All right, so the proximal interphalangeal joint, well, that's going to be the one closer to the origin of the finger. And the distal one is going to be farther away. And that's pretty much it. So then if I have to ask you, Brianna, if I ask you to point out the proximal interphalangeal joint on the first digit, can you do that? Can you tell me, can you direct me?
You said the proximal
interphalangeal joint of the first digit.
I mean, it has the interphalangeal joint, like towards the top.
So you know how these have a proximal and a distal interphalangeal joint?
Yeah, so the first digit it wouldn't have that because
there you go. You're catching on to my trick questions. There are only 2 phalanges on the first digit. So it stands to reason it only has 1 interphalangeal joint. No middle phalanx and no proximal interphalangeal joint, just 1 interphalangeal joint. So if you're referring to the interphalangeal joint on the digits 2 through 5, you'll have to say which one, proximal or distal, proximal or distal. For the first digit, it's just 1. So you'll say interphalangeal joint of the first digit, or first interphalangeal joint is how you would say it. Is that clear for everyone? Cool. All right, so here's some quick practice anatomy for you. Remember, we're spending about 50 minutes on this. Let me check the time. Yeah, we got time. By the end of this, everybody should be able to identify all of these. All right, so let me get my little pencil. And then let me get
Professor, before we move forward, you mentioned the word phalanx.
Yeah.
Can you point at the phalanx?
Phalanx? Phalanx is just a singular word for phalanges.
Thank you.
So 1 phalanx, 2 phalanges. All right, you're welcome. Nakita,
Professor.
what?
Oh,
Yeah, go
sorry.
ahead. We have time, it's okay.
I just want to know where the counting starts from. Like, so does the first one start from the thumb going to the pinky?
Oh, good question. And by the way, if you have questions, please ask them, as long as it's pertaining to this stuff here. So you can see it right here. Who has a question, by the way? Who's
Oh, that was Conlon.
Conlon, take a look. You see it has number 1 on it. Goes
Okay,
from
so
the
number 1
thumb.
always starts with the thumb.
Thumb, yeah, always the thumb. All right. First
Thank
digit,
you.
1, 2, 3, 4, 5. So when I say digits, or the book says digits 2 through 5, they're referring to the pointer finger. Middle finger is number 3, index finger is 4, and little finger is 5. Go ahead, Dandre.
So Professor, for the first digit, it doesn't have a PIP. It just has an IP and an MCP.
Exactly right.
Okay.
It doesn't, because it doesn't have a pip. No. Every time I would teach this stuff, people would use DIP and PIP as acronyms, and then after a while you'd forget, what does it actually mean? DIP. Practice saying it out, even if you think you know it, because then people would just say DIP and PIP and DIP and PIP, but then in the registry they might not even say DIP. They might just write it out or just leave the answer there for you.
It's like it's just distant, proximal, and then metacarpal. But like the first digit, it just has interphalangeal, and then it just has MCP.
Metacarpal phalangeal joint. That's correct.
Okay.
All right. All right. So we have time. The plan is to spend 50 minutes on anatomy. So this one that's circled in blue. Phoebe, what is that bone?
circled in blue,
Yeah, this one right here.
that's the metacarpal, no?
I know it's a tiny bone right off the first
Oh,
digit.
the sesamoid one that you mentioned?
Sesamoid bone. Do not miss this easy layup question on registry type material is what I'm legally bound to say.
Okay.
Sesamoid bone. All right. Rico, which bone is this? B.
That's the first metacarpal.
Fantastic. What is this joint A, Yasmin? What is this joint A?
Carpals?
Huh? Say again.
The first carpal?
No, the joint.
Oh, the
One
joint.
second. Yasmin, what are these bones here called?
The carpals.
Okay, and what are these bones called?
Metacarpals.
So what is this joint?
Carpal metacarpal joint.
All right, got it. Thank you. What is this digit here called, Conlon? Go ahead, Conlon. You got a question or are you answering?
That's the number Q.
Yeah, Q.
That's the fourth metacarpal.
Fantastic.
Carpal. Yeah, carpal.
Metacarpal. Yeah, you got it.
Metacarpal.
You got it. What is this joint here? Michelle, what's this joint here called? G.
That joint is between the metacarpal and the phalangeal. Is it carpal metacarpal?
Well, you started off great. And earlier I asked Yasmin, and somebody's answered for her. And the way how we worked this out in the beginning, we said that these are carpal bones. Let me just get my little pens. These are carpal bones. And these are metacarpals. So then we call these metacarpal phalangeal joints, right? I'm sorry, carpal metacarpal joints. Carpal metacarpal joints, right?
What is that?
So then G is between the metacarpals and the phalanges. What do you think?
Oh, phalangeal metacarpal?
Other way around, we say it. Metacarpal phalangeal.
Okay.
All right. Usually we go from the point of origin to the distal point. So we go metacarpal phalangeal, carpal metacarpal. See the pattern? All right. And then how would we describe J, Garcia? What's J?
That would be a middle phalange.
Middle phalanx of which digit? As specific as possible.
So you said phalanx is the singular, right?
Yeah. Yeah.
Okay, so the second digit.
Second digit.
So
Middle
from the top. So that would be middle phalanx of the second digit.
Fantastic.
All right, thank you.
What do we call this one here? There's no letter affixed to it. Let me get somebody else in here. Someone who has a camera on. Alexander, what's this one? And I've drawn a blue line on it.
That's interphalangeal joint.
This one right here. This bone. You're up, Alexander. If you're speaking, you're muted.
Interphalangeal joint. No.
Can you see the screen?
Yeah.
So this thing that I've circled in blue, what's a joint, Alexander? You're muted again. It's okay. Take a listen now. Weiming, go ahead.
Is it this one is the distal phalange bone of the fourth digit?
Yes.
Okay.
Alexander, joint is between two bones, huh? Two or more bones.
Gotcha, Professor.
Dongwan, you ready? What's N as in Nancy? This one here. What's N?
That'll be mid phalangeal and distal joint.
So close. So we're gonna
Pip?
try to use. Say it again.
Is it dip pip?
So it's one of these. Which one do you think?
Dip.
Dip. What's the D in dip stand for?
Distal and inter
Yeah. And what's this one?
phalangeal.
So distal interphalangeal joint. Distal meaning it's farther away or towards the end of the finger. Inter just means it's between. And between what? Well, between the phalanges.
Okay.
Sounds good?
Yeah.
Cool. This is good practice, I think. And I put up 2 links on there. Hopefully they work. Did anybody try them? The links, I think I put them a couple of days ago. On Sarah, what did you say? I'm sorry.
Yeah, they work.
Okay, fantastic. Just to practice this stuff ahead of time. So, right. So for every if I'm fortunate enough to teach this again, or if I'm requested to do it, then it will be the same thing. You'll get some anatomy practice before we start, so we can make this go smoothly. All right, Gareth, you ready? What's I? What's I?
So I see what's pointing to. I will be the proximal phalanx of the second digit.
So this is a joint right here.
Oh, it's pointing to there. I thought it was pointing to the bone. All right.
H is pointing to the bone.
Right. Not too certain what which joint that is.
Got you. Regina King, go ahead.
The proximal interphalangeal joint of the second digit.
Nice, nicely done. We are doing well with time here, by the way. So we got 13 more minutes before we take a break. We're going to spend the rest of this time on anatomy. You have to know this because go ahead, Dandre.
What's letter I and K? Are those just joints or spaces?
The joint. Well, the joint is a space.
Okay, so that's why I'm getting a little confused. Is like because J and H, you say it's going to be distal interphalangeal joints.
Wait, you said I and K, right? But J is
yeah,
pointing
I
to the
and
bone.
K but isn't it pointing at the gaps in between it though?
That would be the joint.
That'd be the joint. So it's just joint.
Yeah. The dip, as you'll grow accustomed to saying, and that will be the pip, and that's the dip. Proximal interphalangeal joint, distal interphalangeal joint. Take a look right here. See it? Distal interphalangeal joint, proximal interphalangeal joint. So it's the same thing. Doesn't matter which digit you're looking at. That space between the bones. I'm sorry, go ahead.
So then J and H, J would be proximal interphalangeal joint, and then J would be
Wait, start again. Say your letters again, because I think you might be getting them mixed up.
Yeah. H is proximal interphalangeal joint, and then J is going to be.
All right, stop 1 second. So
Big
H,
bones, not joints.
the H is
the
pointing
bone.
to the bone.
Okay, so you just call it bone. They say proximal bone, or it's just digit.
You would call it, and it's on the first slide here. You will refer to it as a proximal phalanx, middle phalanx, and then distal phalanx. And in between we have the joints.
Oh, okay. All right, I get it.
You got it?
Yeah.
All right. It looks like a lot, but I promise you, it really isn't. It really isn't. It really isn't. All right, let's keep going. We still have time to do some more practice on this stuff here. Let me see what we got. No, we'll start this at the next part of this discussion here. All right, so let's try this one. What is this? What is this one called? This joint. Let me pick on someone here. Let me get Edward, what's this one called? I have it in blue. Everybody else, you can type it in the chat if you like.
That is the distal metacarpal of the third digit.
You got part of it right. It's the third digit.
Distal
But this,
phalange, the distal phalange of the third digit, excuse me. The distal middle phalange of the third digit, excuse me.
not quite. So I'm pointing to a joint. I'm not sure if you heard the discussion we had just now. Just to review, the bones are called phalanges. And the joints would be the connection between the bones. And we go from, if there are different bones, we go from proximal to distal when we're naming them. So these are carpal metacarpal joints, so called because they involve the carpal bones proximally. Mute yourself, please. And 1 second. And the metacarpal bones distally. These are called metacarpophalangeal joints because they have proximally the metacarpal bones, and distally they have the phalanges.
So that's the proximal interphalangeal joint of the third digit.
Yeah. What's this one?
The proximal, the distal, is that the distal?
Well, if this is proximal, what do you think this one is?
Distal.
Okay. What's this joint?
The distal interphalangeal joint of the third digit.
Okay, cool. And that's how you work it out. We're just basically doing the same thing over and over. You have to know this stuff because when we start doing looking at the positions and the x-rays, you'll hear these terms and you have to know it. All right, we got 9 more minutes to go through this stuff. Here's where you ask your questions to fill in those knowledge gaps. Let me circle back here to see who else is on here. Anais, I'll go back to that person in a second. Anais, are you ready? You're up. What's this joint
ready.
called?
That is the MCP of the second finger,
Got you. What's MCP stand for?
metacarpal phalangeal joint.
Fantastic. So if I say to you, I'm going to stick with you, Anais. If I say to you, we're going to center for a hand on the third metacarpal phalangeal joint, where am I pointing to? You can direct me. Am I in the right place here?
No, so the middle finger,
Middle finger? How about here?
and then go down.
Yeah?
No, go
All
up.
right. Sounds like you got it. Cool. Let me get somebody else. Ibrahima, what's this bone called? You're muted, Ibrahima, if you're trying to speak.
I said the distal bone. The
Distal
second finger.
bone.
Yeah. No, that's
Do you have the answer?
the phalangeal bone.
All right, take a look here. I see you, Minsu. Minsu, go ahead, actually.
The middle.
One
Yeah,
second.
the middle phalanx.
Got you. So we have proximal. Everyone, you gotta pay attention. You have to pay attention. What you put in is what you get out. All right. This is the only lecture on this. It's gonna be recorded, but you have to pay attention. Proximal, middle, distal. And the first digit has how many interphalangeal joints? Let me get who's here? I can't see her name. Let's see. Is it Nakita? Nakita.
Yes, it has only 2.
Has only 2. Cool. So what do you call this bone here, Nakita? I'll stick with you.
Is that the distal metacarpal phalange?
The bone itself.
Oh. What was it?
What's this bone? coloring it in blue as I used to do when I was younger. Nikki, are you ready? You got it?
Yeah, what is it? A larynx or
I'm sorry?
I'm not sure what it's called.
Okay. Edward, what you got for me?
Is that the distal phalanx of the first digit?
That's right.
Phalanx, that's what I was trying to say. So
That's all right. So I think it was Chris who asked earlier. Good question when I referred to phalanx versus phalanges. One is singular, the other is plural. So you're speaking about these blue bones. I think this is blue. My daughter would say I'm colorblind. These ones at the end. How about that? You call one of them is a phalanx, depending on where you're from, and all together they're called phalanges. All right, so we got 5 more minutes. Let's try this bone right here, but on the X-ray. Go ahead, Dante.
Yeah, so Professor, so for the fingers, it's gonna be phalanges. Metacarpals is the body, and the carpals is the base, right?
Oh, be careful. Each of these long bones have a base, body, and a head. Base, body, and a head.
Oh, each bone has a base, body, and a head. Okay.
Yeah. You can see it. Base, body, head. Base, body, head. They didn't repeat it because it's the same thing, but yes. All right.
Okay.
Base, body, head. All right, so Richard, what's this bone right here? Richard Coffee. If you're speaking Richard Coffee, you're muted.
Which bone again? Can you hear me?
My cursor is on it.
Oh, okay, that'll be the proximal phalanx of the fifth finger.
Or 5th digit is how we like to say it, okay? 5th digit. All right, we still have 3 minutes. We'll keep talking. What did I say this bone is right here? Yasmin. This tiny one right here.
Sesamoid bone.
Okay. What is this joint right here, Yasmin?
The metacarpal.
The joint.
Proximal.
All right, pay attention, huh? Patricia, you ready? Listen to this, Yasmin. This joint, you got it, Patricia?
Yeah, it should be the metacarpal phalangeal joint of the first digit.
Cool. Why is it called a metacarpal phalangeal joint? Let's try to make these questions a little bit more, not tricky, but more involved. I don't like that term. I'm going to stick with you, Patricia. Why is it called a metacarpal phalangeal joint?
Because the first digit doesn't have a third bone. I mean, it doesn't have it only has a proximal and a distal bone, and it's closer to the metacarpals.
Oh, that's one way to say it. I'm going to stick with you, Patricia. Imagine someone is coming from space and they don't have fingers. They only have blobs. And they're asking you, why is your joint in your own little alien language? Why is this joint called a metacarpal phalangeal joint? Which bones are involved is what I'm asking.
Okay, the metacarpal and the carpal joints are involved.
Not carpal. Metacarpal.
The phalangeal joints.
Phalanx. Metacarpal bone and phalangeal bone.
Yeah.
All right. All right. I think the alien would fly away from you, Patricia. I'm just joking. It's fine. It's fine. Somebody's had their hand up. We got 2 minutes. We're going to wring out as much of this as we can so everybody understands all of these. How many phalanges do we have? Let me see who else we got on here. Rico, how many phalanges do we have?
14.
14 phalanges. How many phalanges does the first digit have, Rico?
I'm gonna say 2.
2. Are you sure?
Yeah, man.
All right. Cool. And how many metacarpals do we have? Let me circle back to somebody I haven't called on a little bit. Dondre's got a question. You got a question.
Oh, I was gonna answer.
Oh, let's go.
I got to answer the question.
Yeah, please go.
So there's five, and I wanted to know, do we need to know, for the carpal bones, do we need to know hamate, capitate, trapezoid, and trapezium?
Next week when we do the wrist. Today is just
Fingers.
hand and fingers.
Okay.
That's a quick question.
Of course.
Would you describe the body phalanx of the fifth digit?
The body of it or the
body of it? So like the question you asked Richard like 3 questions ago, I didn't hear the answer. You were pointing at the body phalanx of the pinky.
How would I describe? Oh, okay. I didn't say I don't. Maybe I misspoke or you didn't hear right. I was just asking for the name of this bone.
Oh, up there.
Yeah,
Okay.
just maybe I think is what I'm referring to. But let me just go to it again. So this is the base, body, head. Base, body, head. Same thing for all of them, right?
Okay.
And so this is just called the distal phalanx of the fifth digit.
That's right. Okay. Thank you.
You're welcome. Body, head, base, body, head. All right. We'll take I think we only need a 7-minute break so we can spend more time on procedures. We'll start back again at 9:58. I will stay on here for those who have questions during the break.
Professor, did you check attendance?
I did not.
Okay.
It's going to be tricky because some people are actually doing lab and so on.
Professor?
Yes.
So why is only dip opposite way?
Oh, let's see it. We're getting to an interesting question here. What's happening? Let me get to it.
So you see how metacarpal, phalangeal, and PIP, proximal interphalangeal, those are from proximal to distal. But dip is distal to medial, proximal.
Oh, you're referring to the naming nomenclature?
Yeah.
I see. So these are just between. I see what you're saying. All right, so I was trying to simplify the name so you can understand. So notice how the metacarpal phalangeal joint has 2 different bones. And so the first part of that name, or the naming nomenclature, has the proximal bone, the metacarpal bone. The second part, the phalangeal part, has the phalanx. Same thing with this one, carpal, metacarpal. The proximal end is listed first, the carpal bones, and then the metacarpals after. All right, well, the phalanges, they're all the same type of bone. It's only proximal, middle, and distal. So this distal you see here is referring to the joint, not the bone, because these bones are the same. Hopefully that helped you.
Oh, okay.
All right, so it's all the same bone. If this had a bone A and then that's a bone B, then they would say AB joint, but it doesn't.
So, yeah, on the phalangeal, distal is not the bone, it's the distal part of the middle phalangeal.
It's just so there are 2 interphalangeal. Oh, I see what you're trying to get at. I see. And these questions are important, by the way. So there are 2 interphalangeal joints on digits 2 through 5. We have to find a way to differentiate between them. One's going to be closer to the point of origin, hence we call this interphalangeal joint proximal. One's going to be farther from the point of origin, so we call this distal. But that's referring to the IP joint. Which one is it? Well, the distal one. So you do an x-ray and the doctor says, or the patient says, I hurt. Well, no, I don't know if the average patient is going to say this, but it can happen. Patient says, I hurt my distal interphalangeal joint, or I hurt this finger, this part of my finger right here. Then it's useful for you to write on the requisition, patient indicated injury on the distal interphalangeal joint. Doctors love that kind of stuff, by the way. They really do. During the break, any other questions, by the way? I have some other stuff I gotta say. Any other questions? Okay. One of the things that can happen in radiography, and it's quite common now. By the way, you don't have to stay, by the way. You guys are free to go until the break is over. But I can just keep talking. Is because of the separation between the radiologist and the technologist. What I mean by that, meaning there was a time when the radiologist would sit right next to the tech, or they were easily accessible. Then you would get feedback. Are your images good? Are they good enough? Or you would have a QC officer, quality control officer. Or the doctor will just call you and say, I didn't get this. Where is the injury? Well, because of that separation, now the doctors are in some other room, sometimes farthest end of radiology. We don't have that immediate feedback, but I can promise you they are talking amongst themselves and to your superiors. So it's important that we do the best job we possibly can. That includes naming nomenclature, indicating where the injury is, and getting the best view possible while administering quality patient care. All right, so you got to make sure you know the stuff, and also you're the eyes and ears of the radiologist. An essential part of it. The radiologist doesn't even see the patient. Quite often, the ordering physician doesn't see the patient either. The nurse will put the order in, and so you're basically the first point of imaging contact. All right, so you got to ascertain, okay, is this where the injury is? Is this the right views that were ordered? And you got to make sure you do it the best way possible, and that will take you a far way in your career. It's different from someone who just does what's on the requisition and doesn't always do the best job possible. All right, just remember that your interview process for a job has already started. It has already started. So techs are watching you, your manager is watching you, radiologists are watching you. Even if you don't plan to work where you're assigned, you're gonna need a recommendation. We'll restart again in about 2 minutes.
Okay, so
Oh, sorry. Go ahead.
Go ahead. First, Abigail, ladies first, and then the next person.
Because it's so the lateral for the fan, right? That's what they call it. When a lateral hand is called a fan, like that. I'm seeing it on the slide, right? That's what they refer to because they're trying to see the joints.
Yeah, they want to see the joint sometimes. For any kind of X-ray, it's not complete unless we do two views perpendicular to each other, generally speaking, except with the exception of the abdomen. But the chest X-ray, any kind of extremity, especially, we do two views at 90 degrees. That's just how it is.
Where I'm at, they do 3 view of the hand. They do the lateral. I mean, they do the PA, the lateral, and the oblique. But I didn't know that the fan was looking for the joints.
Yeah, so there's all kinds of stuff. So if there's a fracture, they want to see where is the displacement, right? And that kind of stuff. There are 2 ways we can do a lateral. One's a fan lateral, one's a straight lateral for foreign.
That's what I was coming to, because I know, like, I didn't see, like, one of them said do a fan, but I didn't know what was a fan. So I thought, but a fan view is like looking for the joints itself, and a regular lateral is just to see the bone superimposed. Is that what it is?
Generally speaking, they ask for the regular. We'll talk about it in a little bit, but it's okay to ask now. Like this, if they're looking for foreign bodies, if something's there, they want to see where it is. All right. But if they want to see the soft tissue and which bone is injured, looking at the joints at a different perspective, they do a fan lateral. But good questions. We'll talk about it in a little bit for sure. Give me 1 second.
All right.
Who was the person with a question? Was that you, Chris? Somebody else. Somebody's had a question unmuted at the same time with Abigail.
It was me, but I think I just figured out. Yeah.
Okay. Are you sure? The question might help somebody else.
So okay. My question was, so for the phalanges, so 3 phalanx, we're just looking at it as the same piece, but with 2 joints. So that's why we call those 2 joints proximal and distal. It's not because of those different types of bones. I don't know.
They're not
I don't
named
know how
for
to
the
say.
proximal bone and the distal bone. It's just describing the position of the joints in relation to the fingers.
Yeah, so unlike other joints, for the joints in the phalanges, it's because of the location. We name it after the location of it.
Yeah,
It's not because of the types of the bone.
that's exactly right.
Okay.
That's exactly right. You're right. You did figure it out. You didn't need to ask a question, but it might have helped somebody else. So it's good.
Thank you, Kim.
Nicely done. See, it helps somebody else. Help Chris Garcia. All right, let's get started again. As a reminder, it's useful to have your cameras on. This is how I read the class. But we will proceed in the interest of time. So going forward now, we're going to spend at least 15 minutes on positioning. And for every body part that we do, we're going to go through all of this stuff, right? Patient prep, and I won't repeat some of this because it's going to be self-explanatory. So obviously, the patient has a ring on, or they have a bracelet that's hanging down on the metacarpals. You got to remove all that stuff, right? So remove everything that can obscure. What's that term I'm looking for that it will cause on the image? If a ring shows up, how do we refer to that on the image?
Artifacts.
Artifact. It will cause an artifact on the image. An artifact on the image. General patient position. For patients who are ambulatory, what does that mean, Javon? Ambulatory. In the interest of time, anybody can respond. Because this is a lot of positions here. We got to go.
They can walk.
They can walk.
Walkie-talkie.
Walkie-talkie. All right, got you. That's how we say it for sure. Ambulatory means they're able to move around. Is that what you're going to say, Brianna? Say yes.
Yes.
Cool. So seated at the end of the table, affected side, the unaffected side on the IR. Is that accurate, Avagay? What do you think?
So the unaffected side on the IR?
Yeah.
No, that's not.
Good. Affected side on the IR. So you'll see how this is common sense, right? So I'm not going to repeat this for every position, but pay attention to what will be the common thread for all these positions. The SID, what's a typical SID for an extremity? John Sazakis, I'm sorry.
Right when I got my mouth full.
That's all right.
I'm going to say 40 inches.
40 inches. Sometimes they go higher. Why would they go higher? Say 40 to 48. Why would they go higher?
That's an excellent question. I don't know.
All right. For the textbook and for the registry, no 40 inches. Some places might use it's customary for some places to use a longer SID, 40 to 48. Supposedly increases spatial resolution. Now, with today's high quality image receptors and machines, I don't know how effective that is or how necessary that is, right? But the textbook says 40 to 48. For the registry, no 40 inches SID. All right. ID markers, be sure to use your physical marker and avoid using the digital marker. You might see it in clinic, but it's not it might be legally binding, but because it can be manipulated, you can get yourself in trouble if there's an error. You understand? So make sure you're using your physical marker in the proper way. So you double check. So the way how I would do it is in this order. And the last thing I put on is the marker. This is how I would do it. Now, when you're in lab or you're in clinic, they will have way more experience, at least these days. Okay, then I could, someone have a question? No, okay. Then I can tell you right now. I'm just going by old school what I would do, right? So the last thing I do is put the marker on, and then I would go out and take the picture. Rad protection. What do we do for rad protection for extremity imaging? What do you think, Roxanne?
They cover their legs. If they're sitting down in the seated position, they'll put the shield over their legs.
Got you. What are we trying to cover, Roxanne?
Gonads.
Gonads. What's the gonads?
Female and male reproductive organs.
Fantastic. What else can we do for rad protection, Javon?
Lara.
What does that mean?
Keeping it reasonably low as achievable.
What does that mean?
Keeping the exposure like to a minimum, pretty much. Like like keeping the exposure to the minimum.
All right. I will try to give you some guide as to what the exposure is for each body part, but go with the department protocol. And at some point, you might learn about dose creep, where you assume because you got a good image, that means you're using the right exposure. And then you would not be adhering to the Lara principle. All right, so we use the lowest possible exposure that will still yield a highly diagnostic image. Go ahead, Edward.
Dose creep, to be clear, is the same thing as exposure creep, right?
Yeah. So one more thing we can do for rat protection. Let me get Elias.
What's the question again?
Run rat protection.
Okay.
What's the other thing we can do to protect the patient from radiation? Someone listed Lara, someone listed lead shield. Can you think of anything else?
The Cardinals principles.
Think in practical terms. Anybody have any idea? Go ahead, John.
Automation.
Leave the room or put distance between you and the tube or the exposure, right?
Oh no, I'm just speaking about the patient. We don't care about you. I'm joking. Collimation. I think Elias whispered it just now. Collimation.
Oh, sorry.
That's all right. No need to apologize. Collimation. This is where we get out all the knowledge gaps, right? So collimation. So we're going to talk about that also. I'll give you a guide. All right. IR size, we'll use the appropriate size. So someone has a bigger hand that can't fit in a 10 by 8 or something. I think now they just use one standard IR for almost all the procedures. No one uses 10 by 8 or 8 by 10 or 10 by 12 anymore anyways. But use the appropriate size is what I'm trying to say. Instructions, use clear. Why is instruction important? Actually, it has to do with, that also impacts rat protection. How does that impact rat protection? Patient instructions. Let me get, go ahead, Dondre.
It has a lot to do with making sure that the image is clear when it comes to inspiration and expiration. So like you want to make sure that there's no superimpositions and rotations.
Sure. Well, let's stick with rat protection. How does yes, that helps you get a good image. David had his hand up. David, go ahead. I don't think I heard your voice this whole time. What do you got, David?
I was gonna say overexposure. You don't want to you don't want like the patient to move or something, his hand or her hand.
How
And
would
you
that
repeat the
cause
exam.
overexposure?
Well, you're gonna have to repeat the exam if, let's say, you don't give clear instructions to like stay still, like have their hands still.
Exactly right. Exactly right. Repeat exposure is one of the biggest causes of overexposure. All right, fantastic. All right, so here's how you would position a hand. You've seen this, I'm sure, in clinic. This is how you would position a hand. Which aspect of the hand is in contact with the IR? Let me get Raven. Which aspect of the hand is in contact with the IR?
The third finger or the middle finger?
No.
Wait, can you ask the question again?
That's all right. Which part of the hand is in contact with the IR?
Oh, I'm sorry. It's the palm that's on the IR.
Okay. Because all the fingers are on the IR. So now we're talking about, is it the palmar side or the other side? What's the other name for the palmar side? Anybody?
Pronation.
Dorsal.
Dorsum.
The palmar side?
Anterior. Anterior.
Anterior.
aspect.
Wait one second.
Anterior.
Make sure you
Isn't the
know this.
dorsal?
Make sure you know this.
Yeah, dorsum.
No, the palmar side is not called a dorsum.
I thought you said the opposite side.
No. I'm still with the palmar.
Oh yeah, it's palmar.
Maybe you misheard me or I got tongue-tied.
What's that?
But I'm sticking with the palmar side. I said, what's the other name for the palmar side? I think that's what I intended to say, at least. I think that's what I said.
Volar.
Volar anterior. The back is dorsum or posterior. Make sure you know this.
Question. Is
Yeah.
there a reason why we're not using the term ventral? Is that outdated? And where did volar come from?
We do use ventral, but generally speaking, they say anterior or palmar. It's just it's just a convention. If you say the ventral side of the hand, everybody would know what you're talking about. But it's unusual. Most times they'd say palmar aspect. It's just
Got it.
one that's more recognizable. Go ahead, Chris.
Professor, that last slide makes it seem like volar and palmar are on the same side. Isn't it palmar and volmar? Excuse me, volar?
No, this is all the same side.
So this palmar and volar, same thing.
Same thing. Palmar,
Thank
volar, anterior, same thing.
Thank you.
You're welcome. Back, posterior, dorsal. All right. So this is how we position it. And we want to see and in the description, I have a detailed list of how you should position the patient and so on. I have it broken down into position, collimation and central ray, and image analysis. So I'll just go through them. I won't read all the things. I'll go through the important bits. Take your time to read this on your own. But after a while of doing it and looking at these images, you should be able to immediately see what's wrong with these images, or what's wrong with the position. To start with the position, we're going to make sure that the marker is going to be in the collimation field and the fingers are separated. So none of the soft tissue would be overlapping for the digits. Someone is unmuted here. Okay. None of the soft tissue should be overlapping. None of them should be overlapping. So the fingers should be sufficiently separated. The thumb is going to be in an oblique position, which is just how it is for a PA hand. The thumb is going to be in an oblique. Go ahead, Lee.
So for the hand exam, so for the registry exam, when we are positioning the patient needs to spread their fingers, right? But when I was in clinical, the tech didn't ask the patient to like expand their, like they don't have to separate their fingers. They can just keep their fingers closed like this. And then the tech said it can decrease patient dose. Is that correct?
I've never heard this. Well, it might be a new thing, but I can tell you that this is what you need to know for the registry, and this is best practice. Because let's say, for example, there's some kind of contusion or some kind of foreign body in the hand, or some kind of swelling. You want to be able to clearly tell which digits are involved and which ones aren't. And this is the reason for separating the fingers so the soft tissues do not overlap. Now, you will see all kinds of things in clinic. That doesn't necessarily mean that they are wrong, but this is best practice, and I just explained to you why. The other thing is, remember during the break, I'm not sure if you're here for this, Lee, I mentioned the separation of the radiologist and the technologist. Because you send something in and no one complains, that doesn't mean that's the best image we could have gotten. All right, and it shines, it puts us in a favorable or unfavorable light if we do work that's not always the best quality. In my view, this is the best way to do it, and it's also the view of the registry. Go ahead, Edward.
So at clinic, when we were doing x-rays of the hands, they always did 3 x-rays. They did an oblique, they did a lateral, and then they did a PA.
Yeah, so
Is that always...
We're just on the PA right now. Yes. So it depends on where you're working. Some places even do 4. It depends on where you're working. If you work in a musculoskeletal place, but 3 at a minimum, sometimes 2 at a minimum, 3 as a general routine. So we're starting with the PA.
Sorry for interrupting you. With that being said, are we going to that on the next couple of slides, and are we gonna have to know proper bone positioning when it comes down to that? Is that like gonna be on an exam question?
What's going to be in the exam is listed here. AR content specifications and quiz guide. All right.
Yeah.
Okay. All right. So for the PA, this is how you position the patient's hand, and you center the third MCP, third metacarpophalangeal joint. So this one right here. Why? Because if you're centered there, then those joint spaces will be open. If you're not centered right, then the joint space would not be open. All right, so the fingers should be separated and stretched out, not curved. So that means we would not get foreshortening of the phalanges. If we curve the fingers, then the phalanges will be, the long bones will be foreshortened, and we don't want that, right? Remember that foreshortening occurs when the bone or the body part is misaligned. All right, we want open joint spaces. We want soft tissue on both sides, and we want no overlapping of soft tissue. And no, no foreshortening of the long bones. And we also want the distal 1/3 of the forearm bones, radius ulnar, distal 1/3, even though it's a hand. If you cut it off here, it's substandard. Will they send you back to repeat it? Maybe not. But this is the ideal. These are the ideal structures. These are the ideal structures to include in a hand X-ray. All right, so be sure to read the detailed list of items that I put under the slide. I will not read through all of them here. One question, what is this bone right here, Nakita? What's this bone?
It's a sesamoid.
Okay. Go ahead, Chris.
So we know it's a sesamoid bone. How do we know that you're referring to the sesamoid bone of the hand? What is the name of that bone?
It's just a sesamoid bone of the first digit, or sesamoid bone in the hand. There's only one here, sesamoid bone.
Okay.
Actually, I've seen people with more than one. It was such a weird thing to see
In the
many
hand?
years ago. Yeah. It
Okay.
was it's almost like people who have polydactyly. Anybody heard this term? Yeah.
Right.
But I've seen more than one. But that doesn't mean it's not this. That would be a normal variant. That doesn't mean something that's atypical, but not a disease process. All right. So then, for each body part that we do, each view that we do, we're going to do some practice to see if you can identify what's wrong. So we'll put on one side, typically on the left, the ideal image, and on the right, we'll have one that's not so good. In my view, you might think it's good too. I don't know. Can anybody tell me what's wrong with this image? What's wrong with the one on the left? Let me get Kennedy. What's wrong with this one on the left? What do you think of this one?
I don't really see anything wrong.
All right, that's good. I see if Edward agrees. Edward, do you agree?
I'll say he didn't spread his hands out enough.
The left one? Left one's perfect. This is the reference image. All right. Left one's there's no overlapping of toxicity. That's more than enough.
Oops. Sorry.
That's okay. That's okay. I do this from time to time just to make sure you see this thing left ways and sideways. Conlon, you got a question?
Is it his marker?
Are you referring to the left image or the right one?
The left one.
Nothing's wrong with the left image. It's the reference image.
Oh, so it's the right one that's the issue.
What do you think?
Oh, he has rotation.
Ah, there you go. Rotation. All right. Also in the notes, don't read it right now. Go ahead, Roxanne. You got a question?
No, I was just pointing out it was rotation in the right image.
Got you. All right. And how this is termed, right? And I think this might be useful in the future. I used to work at a school, and the professor was fantastic, real smart man. And he would give you an image, and you were supposed to not only label at least 10 things, but then say what's wrong with the image, and not just say rotation. How do you know there's evidence of rotation? Well, how can we tell? Let's take a look. For the PA, we have equal concavity, we like to say. Concave just means it's curving inside on either side of the digits, right, of the phalanges. You can see it here. But notice on the rotated one, we have unequal concavity. So this side is more concave than this side. That's evidence of rotation. Can you guys see that? So what I want you to get used to seeing is not just seeing it to say there's rotation, but describing it in proper terms, right? So we can see that there's more concavity on this side than here. You say that to radiologists, they'll be so happy. Your manager will give you a raise and you live happily ever after. So how do we know it's rotated? Go ahead, Lee.
The metacarpal bones are superimposed.
That too, yeah. You can see that they're more superimposed than we want them to be. Yeah. So the go ahead, Jeffrey.
You said it's concave on both sides or just one side?
Here on the ideal image, the reference image on the left, it's equal.
Okay.
On the rotated one, we have more concavity. You can see that. Let me draw a little thing. Sometimes if I draw something, you can see it. See how this one has more curve on this side? That's evidence that it's rotated. All right. So it's unequal concavity, we like to say. Go ahead, Garrett.
Thanks.
You're welcome.
I was gonna say you could also see the rotation because of the blending of the soft tissue between the third to fifth digit. You can see the soft tissue is not really separated too
Nicely
great.
done. Nicely done. Get used to using these terms. I like it. I like it. Fantastic. Right? Because we want separation of the soft tissue for the reasons that I mentioned to Lee when she asked her question. All right, let's try another one. What do you think is wrong with the left image? Let me see who else we got here. 1 second. I think is wrong with the left image. Abigail. What do you think? What's wrong with this image?
Let me see.
Left image, this one here.
I think it's fine.
All right, it's good. It's perfect. It's a reference image. Don't fall for that again.
Mhm.
It's the reference image. All right, so now let's look at the one that's, which one am I on? This one here. What's wrong with this one here, Abigail? What do you think?
Um, rotation again, like you said. And then on the fifth digit, it's not perfectly aligned, so you can't see the joints, the interspace joints. So
Could be. Let me see. Angel, we're gonna flush that out a little bit. Angel, what do you got for me?
Oh, I was gonna say that they're hyperextending the fingers too much.
Yeah, we don't want them to be spread out that much. And here's the reason why. So now when you spread the person's finger out, you're trying to fit that on the same size IR. Now you can't center where you're supposed to center. Where do we center for a hand x-ray, PA hand? Go ahead, Angel. What you got?
I'm sorry, could you say it one more time?
Where do we center for it? And where is the central ray directed for a PA hand?
The third phalanx.
Mm-mm.
Can I try?
In the
Go ahead.
middle?
Is the third metacarpal bone?
No.
Professor, it's third
Joint.
metacarbophalanx joint.
Go ahead, Kazi. What are you saying?
Sir, it's third metacarpophalanx joint.
Third metacarpophalangeal joint.
Yeah.
I said it here, and it's on this one, and it's also on here. Go ahead, Edward.
Yo, I don't want to sound. I always. It's on the knuckles. It's on the knuckles.
We're not saying that. Let this be the last time you say this here.
Sorry. Metacarpophalangeal joints.
Third digit.
Third
Right
digit
here.
of the third
So
digit.
if the person's hand is spread out, one, you risk cutting it off. This is almost cut off over here, first digit. And now you can't center here. So we don't need this amount of separation. We need this amount of separation. Go ahead, Kennedy.
For the metacarpal and the carpals, is it superimposed a little for that image?
Metacarpal and the carpals.
Like where the joint space would be between.
Not really. I don't
Okay.
really see that, but no, I think it's about the same. It's about the same. They just spread out too much here. Spread out too much. And this presentation is also overexposed. They prefer this, I think, generally speaking. But you can always window this in clinic. All right, let's try this one. What do you think is wrong with this image, Rico? What do you think?
I would say that's something with the soft tissue.
Elucidate.
The fourth and fifth phalanges, the soft tissue looks like they're kind of overlapping.
There's a more glaring problem we have. Let me get Conline, it looks like. 7 people want to answer. Oh, I gotta pick one.
His
Conline, go
hands
ahead.
his hands aren't flat.
Hands aren't flat. Okay. Let's see what the others want to say. Alex, what are you gonna say?
Yeah, the same thing. Is not flat to the IR. He has he's doing almost like a fist, half fist or something.
That's right. Now, how would we describe the appearance or the presentation of these long bones here? Because of that. I'm sorry?
Superimposed?
Just one person. Because
Foreshortened?
Foreshortened. See? Foreshortened. Remember that foreshortening? Go ahead, Brianna. You got a question or a comment?
Oh no, I was just gonna say that it looks distorted.
Fantastic. All right, cool. This is not good. And in the notes of here, I have the analysis of it and how you should correct it, right? But don't look at it right now. I want you to think about it before. This is why I didn't want to upload the PowerPoint, but this is for your benefit afterwards, right? So in the notes of these PowerPoints, I have the analysis and how you would correct it, as in what's wrong with the image. All right, so now we're looking at the PA oblique hand. And ideally, we want to use a sponge. Have you guys seen this in clinic? You haven't seen it?
Yes,
I've never used a sponge, but
Yeah,
I've seen it, Professor, but they don't use it.
they don't use it. Okay, all right.
Yeah.
That doesn't mean that you have
Yeah.
to. You can do it like this too, right?
No.
But these are just 2 ways you can do the oblique hand. The oblique hand. All right, so this is the PA oblique hand. And now to notice for the PA hand, the thumb is not in a PA position. It's still gonna be oblique. For the PA oblique hand, now it's closer to a lateral. Unfortunately, this is how it is, right? So for this one, we want to use a sponge. What's the benefit of using a sponge sponge. Let me get Nasir. I haven't said that name this whole day, I don't think. It doesn't have his camera on. Let me get to
Yes, Professor.
okay, what happened to your camera?
It's not on right now. I'm about to turn it on.
In the interest of time, we have a short time here. Let me see what we got here. Go ahead, Dondre, you got a question or a comment? Why we use a sponge?
I use a sponge because I believe it's more radiolucent and it's comfort for the patient, so it doesn't strain them when you're positioning them for the desired X-ray image.
Yeah, as much as possible, use an immobilization device. This is the type of immobilization device. Go ahead, Brianna, you got a question or a comment?
Oh no, I was just gonna say that I feel like it would be easier for the patient to position their hand. That's
Yeah,
all.
that's how it is. That's how it is. All right. And we don't want the thumb and the first digit to be touching for the oblique hand. They're a little bit separated. And you still separate these digits. So I kind of like this. I would separate these a little bit more, but yeah, I mean, you don't want to break the person's fingers or exacerbate the injury. Has anybody heard that term before? Make sure you know that exacerbate the injury, make it worse, right? But as much as possible, you still try to separate the fingers to separate the soft tissue, and this is how you position it. Where do you think we center for? Go ahead, Weiming. Got a question or comment?
Yeah, Professor, I just have a question. You said that we don't want the thumb and the second digit close together?
Touching.
Touching together. Okay, thank you.
You're welcome. Brianna, you got a question or comment?
Actually, never mind.
All right, no worries. All right, so we're going to angle the patient's hand 45 degrees, and we're centering at the same place we centered for the PA hand, which is the third metacarpophalangeal joint. And as always, we include 1 inch of the distal forearm bones. All right, so let's take a look here. Which of these is ideal and which is not? What do you think, Leila? Which of these is nice, which is not?
The one on the right.
The one on the right
wrong.
is good or is not?
It's not good.
It's not good. Why?
There's some rotation at the externally.
Oh, Jesus. I have never used that term, at least not today. That's fantastic. So she's referring to this kind of rotation as evidenced by what?
The metacarpals,
What about the metacarpals?
they're superimposed and overlapping one another.
Fantastic. Fantastic. Someone asked about sesamoid bone. See another one right here? John, go ahead.
What's the term of the amount of space we want to see between the metacarpal bones when they're in the oblique position?
What's the term?
Yeah, like I know that that's what we need to see, and that's what my texts have pointed out to me. Is there a term, or is there just, you know what I mean? Like if you were to ask us how we would put that into words.
Got you. As long as you have the patient's hand at 45 degrees, then you get what you get.
Right. Okay.
Right? You get what you get. That's how that is.
But to go back to the two images we were looking at for comparison, the one on the left, I feel like we see more space between the metacarpals. Even though that's slight in the middle there between the third and the fourth, we don't see that in the right image.
That's
which I'm
exactly right.
assuming is the incorrect one.
That's exactly right. So
Okay.
the textbooks would say slight or a little bit, these little ambiguous terms. I
Mhm.
wish they were more specific. There's not a measurement because everybody's anatomy is going to be a little bit different.
Got it.
But if you see no separation, one second, Lena, if you see no separation, that's a problem. That means you rotated the hand too much. If you see too much separation, that means it's closer to a PA than an oblique. All right, so the textbook
Yes.
describes it as a little bit of separation. Couldn't be any more random than that. Go ahead, Lena.
Why is the left image considered an oblique if it's not an oblique positioning?
It is, because you can see there's a little bit of separation and there's more superimposition of the bases of the third through fifth metacarpals.
But they don't necessarily have to do that position with the hand like this for it to be considered oblique.
This is how it's done.
That's how it's done?
Yeah.
Oh, it doesn't look like that.
Yeah, this is the same image. This is
Okay.
And this is the reference image here on the left.
Thank you.
You're welcome. See, right there, Bob. Bob. Let's try one more. What do we think about, go ahead, Lee.
So for when you're doing the PA oblique position of the hand, you want the patient to open the joint space, right? So could you point out how can we identify whether or not the joint space are open?
Oh, very good question. So let me see if I can make this. I don't want to make it larger. You can see it. You can blow your screen up if you like. You see this joint space is open here. You can see that, right? You can almost put, you can see that there's a clear separation between the head of the second metacarpal and the base of the proximal phalanx, right? You can see that open there, Lee. Can you see that?
Yes, but I'm actually comparing this image with the PA. I can't tell the difference. That's why.
So with the PA, you can see the joint space is open also.
Yes.
Right? Here's an example of a joint space that's not open. You can see the back part of it. See that? It's not open. And that has to do with centering. If you mis-center it, then the beam will not be going right through. There's another diagram I have on here that shows why centering is important to get an open joint space. And if we look at the oblique, if you don't oblique it right, that joint space is not open also. All right. All right. Next image. What's wrong with this one? I think did I ask about this already? I don't think so. No. Don Juan, what do you got? What do you think of this one?
I think, I don't know. In my opinion, that image is okay to use, I believe.
As an oblique? Nah, not at all. Kennedy, what you got? Kennedy's gonna tell you why. Kennedy will send you back to repeat this, Don Juan.
The fingers aren't separated enough.
That could be it. Yeah, what else can we
And
say?
it looks overexposed.
So the left one is the reference image.
Oh,
The right one. All right, so this is perfect.
yeah.
This one's not so much.
Mm-hmm.
Oh. Let's see, Dondre. Was it Dondre? Dondre's got a lot of questions. Wait 1 second. Let me give somebody else a shot here, Dondre. Phoebe, what do you got?
I honestly think it looks more like a PA than an oblique. It doesn't
Oh,
look like
very good. Fantastic. All right, so here's how we're going to word this now. So we talked about this fake or this failed attempt at a PA image. And we said this is a failed attempt because instead of it being flat, the palmar aspect of the patient's arm flat on the IR as in this image, it's a little rotated. And how do we know this? As evidenced by there's more concavity on one side or the other. So it's oblique, right? In the PA, it's equal. It's supposed to be equal. So on this oblique image, we don't have enough obliquity. Obliquity. I think that's how you say it. Right? So notice how the concavity is not as exaggerated on one side or the other. So this is closer to a PA than an AP, than an oblique, I'm sorry, than an oblique.
Professor?
Yes, please go ahead.
So the obliquity, I don't know how to say it, but it looks around same amount as left image and right image. So the concavity difference, unsymmetrical concavities, the amount of unsymmetrical concavities, it looks around this similar, no?
Take a look here.
Oh, okay. That part, yes, I see.
And the other bit here, go ahead, Phoebe, before I answer.
So for the oblique, my understanding is that you're trying to get like a different view of the bone. So it's not like the AP, but like just slightly inward, right? And that's how you would, I guess, assess for it as well.
What do you mean slightly inward?
Like you're trying to get the side view, but not all the way. It's not like a lateral.
Oh, I see, like an in between lateral and PA. Okay, yeah, sure. So then if we look at this also, I think it was Sazakis who asked this question. And the terms we used were ambiguous. We said that the separation between the metacarpals, the space between the metacarpals should be slight. But there's too much separation here. This is close to a PA. And this is the other reason why we know this is not oblique enough. Here's another one. What do you think is wrong with this one here? Let me get Edward. What do you got for me? What do you think is wrong with this one? Reference image is on the left.
It's too rotated.
Too rotated. Is it externally? Is it internally?
I'm not 100% sure. I just know that they wrote. I'm sorry. Yeah.
There's no need to apologize. Someone used this term earlier, so I'm just using the lingo since we're advancing or vernacular. Does anybody have an idea? How is this rotated? Who was the lady who said?
Professor, isn't it lateral?
Is it? Oh yeah. Sorry. Laterally rotated, Professor.
Yeah. What happened to my thing here? Lost one of my screens. Give me a second.
Can I try again?
Yeah, go ahead. Yeah, go ahead. What you got?
It's rotated externally.
There you go. You could say that, sure. Let me see if I could get this back on. All right. That's okay. All right, so there's too much rotation on this one. It's closer to a lateral than an oblique. And what's the degree of ankylation of the patient's hand? What are we going for? Let me get Chris. I can't see the names anymore. Let me get Chris. What are we going for?
I want to say 45.
45 would be the right answer. 45 would be the right answer. All right, and there's one more practice. Do this on your own time. In the interest of time, we're going to go on a couple more practices on here. We're going to go on to the fan lateral. Someone asked about this earlier. Fan lateral. Fan lateral. Now, why is this called lateral medial projection? Why is this called lateral medial projection? Going back to the positioning terms that we mentioned at the beginning. Does anybody know? Go ahead, Kennedy.
It starts going through what's it called? The X-ray starts from the lateral and then goes to the medial.
Perfectly said. Perfectly said. So the thumb side, in the anatomical position, the thumb side is on the lateral aspect of the patient. That's the thumb side, radius side, same thing. That's on the lateral aspect. And the pinky finger, the fifth digit, is on the medial aspect. Make sure you know this. This is going to be important when you're referring to the fingers to say which side is medial, which side is lateral. Give me 1 second here. Let me see if I could get my screen back. All right, here we go. Now we're cooking with grease. There you are. All right. That's a fan lateral, and we center right at that we can't be the third MCP anymore. We just say the metacarpophalangeal joint, but we can't see the third MCP now because it's all superimposed. But we center at the one that we can see. It's right there. Let's do some anatomy. What's this bone called? What's this bone called? Sarah, what do you got for me?
The distal phalanx.
Of which digit?
Of the fourth.
Not quite. It's the longest finger.
Oh, sorry, I'm like backwards. So it's a third.
Third digit. All right. Third digit. I missed who unmuted just now or put their hand up. All right. Okay, so here's how we would do it. Again, I put it in here, positional instructions. Some of it's going to be repetitive. The important things on here, the thumb and the first digit should not be touching. Now, you might see it in clinic. Know this for the registry and for the quiz. They should not be touching. Why shouldn't they be touching? We want a clear separation of soft tissue as much as possible. All right? So they should not be touching. Ideally, we want about, well, some people might say about an inch above the soft tissue on the superior end, and a third of the distal forearm. You're going to see that repeating for all of these, except the fingers. So that's how much collimation there is. Now, you can just say tight collimation. Some people might say, and it used to be practices, they would say, give a little wiggle room because the patient might just wiggle a little bit. And if they're outside of the collimation field, then you have to repeat it because now the soft tissue is cut off. Go ahead, Roxanne.
So this specific position is called the fan, and the projection is lateral medial.
The projection is called lateral medial. That's exactly right. That's exactly right. So we refer to projections, I think it was Kennedy who said this. I think this is review for most of you, if not all. Projection describes the direction of the central ray, the X-ray beam, which side it enters first and exits after. So it enters the lateral side and exits the medial side.
Yes, but this position is specifically the fan. This
Yeah,
right.
lateral hand projection. You could just say lateral position also.
Okay, thank
All right.
you.
You're welcome. Any questions before we start into practice on this? Cool. All right. Here's another way we can do this, and we typically do this for foreign body because everything's superimposed. So if someone has a nail or a needle or something in their hand, they're going to ask for this type of lateral, generally speaking. In any case, make sure you know which one they're asking for and do just that. In lab, you might do either of these. For the ART specifications, this is what you should know. PA, lateral, and lateral oblique. All right. So let's practice. Someone's beeping. I don't know what that is. Please mute that or turn the beep off. So let's try this one. What do you think is wrong with this image? Let me get Layla. Layla has her hand up. You got a question or you're going to answer this one?
I had a question.
Go ahead.
So could you just kind of explain the contact that the hand has with the IR for the lateral medial projection? Like, is it the fifth metacarpal touching the IR? I can't really tell from the picture.
Well, this is the thumb, and the thumb is the first one.
Right.
The thumb is the first one. So the fifth is the little finger. All right?
Right.
So then for this one with the little finger, the fifth one is touching. And that is the medial aspect of the hand. You with me, You with me? Was it Lila?
Yeah. So what makes it lateral medial?
The projection describes the direction of the central ray, like Kennedy said. So it's entering the lateral aspect of the hand, this side, the thumb side, and exiting the medial aspect of the hand, the little finger side.
Okay. Okay.
Yeah, you got it?
Yes, thank you.
Cool. Sarah, you got a question?
I just want to add to what I'm saying. It's lateral as in that anatomical position. Like, so it would be anatomical position. So this would be the lateral because that's how you're standing. Even though, like, if this seems lateral. Is it because of that?
Oh, I thought you were making explanations. I wasn't even.
I was going to say the same thing just to clarify that because it confused the hell out of me, and I think Sarah's got the point. Yes, we're looking at it anatomically, and that's why the thumb is on the outside.
Is that correct?
Yes. Oh, you're asking me. Okay, I got you. I'm sorry. I thought you. That sounds like you're explaining, and it sounded fantastic. So if we looked at the anatomical position, I don't think I have a picture of it here. If you stand in an anatomical position like Sarah just demonstrated, with your arms by your side, palms facing forward, your thumb is now on the lateral side. And when we refer to lateral and medial, we're speaking about the anatomical position, right? So the little finger is now medial, the thumb is lateral. Layla, does that help? And John, does that help? Sarah is correct. Good? Every little bit helps. So it's okay to speak up and try to explain to each other.
Yes, thank you for explaining. Thank you.
You got it. Thank you, Sarah. Hopefully that helps everybody else too. Let's continue on with a little practice. All right, so we were here. And what do we say is wrong with this one? We might dig into the question and answer part of this a little bit, but it's fine. because I'm asking you questions throughout anyways. What do you think is wrong with this one? Let me see. No one has your hand up. Let me get Garrett. What do you think, Garrett? You like this one? You don't like it? What do you think?
No, it's horrible. It's
Oh no. Oh no.
it's a lot of superimposition of the digits. There's no clear separation. Um, actually,
What do you think about this? I'm gonna
that's a
stick with
good
you, Garrett. What do you think about this business here, this part here, compared to this one?
in terms of the I'm trying to figure out what it is. It's not right, I know, but I'm trying to figure out what. I know the positioning of the hand is what's throwing everything off. I'm just trying to
That's
see
all
what
right.
you're getting at.
Phoebe's got the answer for you. I think I saw her hand up. Phoebe, what you got?
The metacarpals are meant to be superimposed, but in the image on the right, they're not. And that's
Fantastic.
correct.
Fantastic. Got it, Garrett? You got it?
Yeah, I'm there.
All right.
I'm with you guys.
Cool. We're not leaving anybody behind. As long as you pay attention, you'll get this stuff. Jeff, you got a question or a comment?
I got a question.
Let's go.
With the lateral, is it supposed to be uniform, the metacarpals?
Oh, what do you mean?
Like the metacarpals, is it supposed to be like uniform in the image? Like the left one seems like superimposed, basically.
Oh, I see. You're saying if they should be superimposed?
Yeah, superimposed uniform, like well put together, if that makes sense.
Sure. The terminal, and this is fine if you're unsure about the terminology. This is why we're here, right? So together we'll get this stuff. Ideally, we want all the metacarpals to be superimposed. Ideally, hence it's called a lateral, right? So all the bones are on the side to be superimposed, with the exception of the forearm, which we'll talk about next week. It's impossible to get it perfectly superimposed all the way. But in any case, for the metacarpals here, they should be properly superimposed. Here they are not. See it, Jeffrey? All right, let's try another one. Lee, you got a question or comment?
I have a question for the lateral hand extension projection. Because yes, this one. So the image on the right side, the thumb, the first phalangeal didn't show entirely. So is it acceptable?
Got you. Good question. Very, very good question. Back in my day, it wouldn't be, because what you get on film is what you get, and then you'd say it's overexposed. All right. Because now the doctors can window and change the contrast and brightness, they can fix that. So we would not repeat this exposure because they can window it. In any case, they would not be doing this procedure for the thumb. If it was for the thumb, it would be properly demonstrated. All right, go ahead, Dongwon. Am I saying your name right, Dongwon? Am I saying it right?
It doesn't really matter. It's okay.
No, how do you say it?
It's Dongwon, yeah.
Dongwon?
Yeah, Dongwon.
Dongwon, got it.
So, for the lateral hand extension projection, what is the diagnostic value in that?
Oh my God, this guy's just diagnostic value. I like it. Generally speaking, they do this for foreign body, generally speaking. But depending on the clinic you're working at, if you're in musculoskeletal, they might order this to look at if one bone is subluxated or something, all kinds of reasons. But generally speaking, we're looking for a foreign body, generally speaking.
Maybe I don't know how to read it, or I don't know how to look at it specifically, but everything is superimposed and I'm barely able to see like which one is first, which one is second.
I see. Okay, I'll answer it in a different way in just a second. Minsu, did you have your hand up?
Oh yeah, it's pretty much the same question, like what's the value of this projection? Because for clinicals, I haven't seen any of the lateral hand extension projection besides the fan projection.
All right, fantastic. So let's take a look here. Let's say I don't want to pull something gory up, but imagine with me in this mental exercise. This patient has been shot with a pellet gun. It's going to be a little bit, I don't know why I come up with these violent examples, but it is what it is. And so we have one pellet stuck in their hand, and the radiologist or the primary care physician wants to know how far is the pellet. Is it anterior to the bones? Is it posterior to the bones? Well, the best way to see that is with a fan lateral. That's one value of this. All right. Generally speaking, they do a PA, oblique, and fan lateral, generally speaking. But this is possible also. All right, so I don't have practice on here for this extension lateral because it's not one that is routinely asked for, but it is possible. All right. Okay. What about this one? Go ahead, Eric. What you got for me?
I just had a quick question. If you're doing bilateral hands, can you do them both in the same image, like in one shot, or do you have to do them individually?
You can, and it would save exposure. Like killing two birds with one stone. That's a terrible phrase, but yes, you can. Go by department protocol, by the way.
Okay.
But you can. Eric, you got, oh no, that was you. Somebody has a question? Lee, got a question?
Yes, when you're taking image for both hands, where should the center ray be centered?
You're gonna be in between.
In
between. Go by department protocol.
Okay.
Go by department protocol. All right. But there are views where you can do both. There's a view that you would call that you do like this, like a baseball catcher thing. We won't go through that today. It's not on the registry, but it's something that you should know about. And there are other views that it's not even in the book that the musculoskeletal people can ask for. But it's easy to find out because they would have protocols in the department that list these views and how to do it. Right, so you might go in a musculoskeletal clinic and they ask for some weird view, and I never learned that. That doesn't mean you can't figure it out. What's important is you know the anatomy and you know how to operate the X-ray machine. There's gonna be some literature that tells you how to do it, and beyond that, there's also YouTube University or Google College. All right. So what about this image here? What about this image here? Let me get Justin Kang does not have his camera on. Angel has a camera on. We got Angel. Angel does not have camera on either. Oh, here we go.
Sorry, I turned it off. I was trying to turn the mic on. I might be wrong, but is this one taking medial lateral instead of lateral medial?
No. This is the left hand. This is the right hand.
Oh, okay. Sorry, my mistake.
There's no need to apologize. Do you see any difference? I'm going to stick with you, Angel. Do you see any, before I get to David, do you see any difference with this image and this image?
Hold on. Let me look at my computer so I can see it bigger.
Don't worry, we have time. And I'm not being facetious. We do. If you don't, it's fine.
Not really. I see like the metacarpals, they're a little more like they're not as aligned as it is with the.
Yeah, that's a part of it for sure. Let me jump to David. What you got, David?
Is it the first digit and second digit tissues touching each other?
Yeah, we don't like that either. So two things so far. We got the metacarpals that are not superimposed, and the first and second digits are touching because the soft tissue now are overlapping. We don't like that. What else we got? Hui Ming, what do you got for me?
The pinky, the fifth digit is not showing on the image.
Oh, and then we got the rest of the soup, right? So these digits are superimposed. We don't like that either. We don't like that at all. Somebody else have a hand up? Let me see who's that. Lee, you got a question or a comment?
Oh, the carpal bones. The carpal bones have too much gap, and the ulna and the radius are not superimposed enough.
Yeah, so it's all rotated. Just to be clear, let's say there's a manufacturing defect, and if you're religious or not, but this is the term I use, right? And since we're interested in the hand bones, we wouldn't care so much about the distal radius and ulna. As a consequence of rotation, they would not be superimposed. That's correct. But this would not be the area of interest, the region of interest. Up here is the region of interest. So you would repeat it for the presentation of the hand bones, but not for the radius and ulna, since we're not interested in that.
But would that be a criteria to analyze if the patient being positioned correctly?
Yes, it could be a secondary criteria, but you wouldn't list that as a salient or obvious criteria before you list the fingers touching, the metacarpals not being superimposed, and the digits superimposed when they shouldn't. Gareth, do you have a question?
Yeah, quick question. I don't want to take up too much time, but
That's okay. Go ahead.
for this position, is there a positioning sponge that helps? Because I know there's some kind of bone pathologies that might make it hard for the patient. I know some patients have like a bent pinky or um, different types of pathologies that might make it hard for them to do that position. Is there any kind of sponge for that
Got you. Good
or
question. So
position device?
ideally, okay. I get you in a second, Don Juan. If the patient is able to, and if you can do it without making the patient's injury worse, then you could put a piece of gauze between the fingers, as long as it wouldn't make it worse. And you could also put a sponge under here so they don't tend to drop the thumb and first finger down, right? Like a sponge under here just to rest it on. There's all kinds of sponges and immobilization devices in clinic. Look for them, use them as much as possible, and follow the department protocol. Don Juan, what do you got for me?
Yeah, for the fan lateral, does the obliquity of the first phalangeal matters?
First
First
phala-
digit?
first digit. Okay, so it should be equal. So this is going to be closer. Take a look here. Oh, good question. So this is going to be closer to a PA thumb than when you actually do a PA hand. But we don't really look at it for actually that's a good question, you know. Take a look here at the proximal phalanx. It's almost equal. Almost equal. But they wouldn't repeat this one because here is not equal. And it's still well within the acceptable diagnostic range, as they like to say. All right, so I don't have that listed as a criteria, as an equal concavity on both sides, because now it's not going to be a proper PA or AP thumb, but it's closer to a PA thumb than even the PA hand. Here, the thumb is oblique. All right, does that answer your question?
Yeah, thank you.
You're welcome. All right, we can take a 5-minute break and come right back. I'll stick around for those who have questions through the break. We'll just roll the question and answer part of this into the rest of this. Go ahead, Leila, you got a question.
Yes, okay, so it's a little bit further up, but I was just looking through the slides. And I just wanted to know, is lateral a position? Because when I'm looking at the lateral hand extension projection, if we're going by projection being where the central right enters and leaves, wouldn't it still be considered lateral medial?
A lateral medial position? No, you would say lateral position.
Okay, so what's the difference?
There's no difference. If you're in a lateral position, that just means you're on the side. Then which side will the X-ray beam enter first? That's when you use the descriptor lateral medial or medial lateral.
The lateral is a position.
Lateral is a position. That's correct. So
Okay.
when you do a lateral chest, it's a lateral chest. But then you would say, is it right lateral chest or left lateral chest? You almost always do a left lateral chest. If you do lateral decubitus, is it right lateral decubitus or left lateral decubitus?
But for the hand, it would just be lateral medial or lateral.
You just say lateral hand.
Okay.
Lateral hand. But then as far as projection, you would say lateral medial.
Okay.
Just so inquisitive alien comes to Earth and asks this question. This is how you would answer this. Sounds good?
Thank you.
You sure you got it?
I think so. Yes. Thank you.
Would you like another example?
No, I think I got it. It's okay.
Okay.
Thank you though.
You're welcome. No other questions? Yes, Abigail, if I can hand up.
Yes. So, you said lateral, right? We're looking for foreign bodies
The
in the
extension,
lateral.
generally speaking.
Mm-hmm. And then for a fan lateral, like we're mostly looking like, is it at the joints with also for foreign bodies, or you want to see what's going on in between the joints, like for fractures, stuff like that?
That's when you're looking for fractures, some kind of soft tissue injury, that kind of stuff.
The
Because things
soft
are
tissue.
not as superimposed. So you'd almost always do the fan lateral in addition to the PA and the PA oblique. The extension lateral, generally speaking, remember this is not an exclusive thing because depending on where you work, they'll have all kinds of protocols.
Mm-hmm.
Then you do the extension, and also in my experience for foreign body, generally speaking.
Okay.
Right?
So just to stretch it in the PA, what are the radiologists looking for really in the PA? Is it to compare like the rest of the images?
In the PA, the regular PA,
The regular PA.
the
I wanna know.
regular PA is your starting position.
Right.
This
So
is your
there's
start.
no. Okay. So they're not looking for. Okay. All right. I got it.
Yeah, it's just that's like a PA chest. That's your starting position. You
Okay.
use that to compare that against the lateral and so on. All right.
Mm-hmm.
Don Juan, you're welcome.
Yeah, it's just my personal curiosity. Let's say you have minor fracture on the anterior aspect of the base of the phalangeal.
Okay, sure.
Um, would it show on the PA projection of the X-ray?
Yeah, you would see it for sure.
Oh,
You would see it, and then they would need one of these views now to get a better picture of it.
yeah,
The
but I see
base.
some of the oblique or lateral images have superimposed base part.
Yeah, I know. Like
So
this one here, it would be hard to see it. So they would they
yeah,
would diagnose that the bit that would diagnose the base of the proximal phalanx. Is that what you're referring to? I think you said, right?
yeah,
The oblique would be more useful for that view because everything is
okay,
superimposed, like you correctly said. Nicely done. Nicely
okay.
done. Later on, we're gonna see one of these images has an abnormality on it. I don't think I've happened upon it just yet. But I'll see if anybody can point it out. When we get there, I'll ask it. Let me get some water. No other questions? I can step away for a second. Be good? Okay.
Do we have class on Friday, guys?
Nah, I think it's like academic advisement.
Friday, yeah, we don't have class.
Oh, okay.
Still gotta ask Mickey.
But academic advisement is in 2 days, right? Like one day for these people, one day for other people.
Yeah, for
Yeah,
Tuesday
Tuesday and
and Friday.
Friday.
Tuesday and Friday. Okay, okay.
We got clinical tomorrow, right?
No, I got
Oh,
advisement tomorrow.
I'm the only one, so I gotta hit up Hutchinson to see if I'm still actually gonna go. If not, I got a day off.
That's nice.
No days off.
So people who have advisement tomorrow is not going to clinical after.
No.
That's weird,
Yeah. Yeah.
Hallelujah.
I think we got an unofficial week off. I think it's only today we have class.
Oh, it's only today. And
Yeah.
okay.
So we gotta study our butts off for
Thursday we all going to clinicals though, right?
yeah.
All right, thank you, Dondre.
No problems.
All right, let's get back to it. Right here. Please mute yourself.
Professor,
Yes.
I have to head out to start getting ready and leave to go to lab.
Okay. This is being recorded. I will post it on a as a YouTube link.
All right, thank you.
You're welcome. You're
Have a
welcome.
good day.
You too. Okay, there we go. All right. Shall we continue? I don't know. There's an echo here. Let me see who's thing. Please mute yourselves. Okay, 1 second. All right, here we go. That's better. All right, wait, I got a couple chats. Let me see what this is about. Is this just hello? I just wanted to. The boxes fractured based on the slides on the chapter. Also, what we learned. It states that the fifth is. It states that the fifth metacarpus is. It's a fourth. Based on the documents that I have, the fourth is it's January the 5th. I think I didn't see that chat. I'm sorry. It's January the 5th. Tell you what, it's a safe time. Let me bring up I'll send you something afterwards, okay? Could you send me an email? Person who sent me that chat about the boxes fracture. Send me an
Yes.
email and I'll send something out to the entire class, okay? Somebody had a question. Eric, go ahead. What you got?
Professor, just a quick question because we were learning some information before with Professor Ba.
Mhm.
Is the test just going to be strictly the stuff that we're learning with you, or is it both from both teachers?
The quiz it will be the same setup as what I do for physics and rad protection. So what we learn now will be on the next quiz. What we learn in
Okay.
between that will be in a subsequent quiz. The final will be everything.
Okay, sounds good.
All right.
Thank you.
You're welcome. All right. So we've done the hand. We don't know the anatomy now, and now we're gonna do the fingers. PA finger. Now notice on this we don't include the distal forearm because we're just interested in the digits, the entire digits. So the PA. Here we have the PA fourth digit and the PA second digit, and this is how it's done. Now you center, excuse me, to the PIP. What does PIP stand for again, Phoebe? What's PIP stand for?
PIP.
Mm-hmm.
Larynx. Inner. I have no clue.
No clue, you say? No clue.
Inner phalanges.
Phoebe, no clue? Really? We've been here for 2 hours.
Yeah.
That doesn't Donji, what do you got for me?
Proximal interphalangeal joint.
Proximal interphalangeal joint. No clue. All right. Evaluation criteria. Before we look at that, so someone asked about the central ray and how does it impact the opening of the joint? Well, if you center through the joint, remember the beam is diverging, so we're going to get an open joint space. This is why it's important to properly center your X-ray views. All right, so include the entire finger and at least some places say a third, but ideally all of it. Ideally all of it, the metacarpal. So even though we're doing just a digit, include from tip of the finger to all of the metacarpal. But at a minimum 1/3, center to the PIP of interest. Which digit do we think this one is? Which digit is this one? First, second, third, fourth, fifth?
Third.
Third. Regina, do you agree? Regina does not agree. Let's see. Regina, you got it?
I do.
Okay, you got it. Cool. No evidence of rotation and no foreshortening of the phalanges. All right, so quick practice. This rest of this is going to be real easy, I think, because we've done the hand, which I think is the business end of this little presentation here. So the rest of this now, the fingers are part of the hand, should be a cinch, right? What do we think about this image? Let me get neither Raoul nor Jacqueline have their thing up, but it's okay. Let me see. Javon, what do you got for me? What's wrong with this image here on the right?
Is this supposed to be a PA?
This is supposed to be a PA, that's correct.
Mm,
Think anything wrong with it? Is it good? Is it not good? What do you think?
it looks fine to me, but I want to say that first, what is it? What do you call it? The phalangeal metacarpal joint is a little rotated towards the middle one. If not, then it looks fine to me.
It's fine, actually. There's nothing wrong with it.
Okay, yeah.
All right, what
okay.
is this bone here called, Javon?
That is the proximal phalanx,
What about this one?
the distal phalanx.
What's this joint?
The that is the proximal interphalangeal joint.
Say the word again. The middle word, the I one.
The proximal interphalangeal joint.
Inter, I-N-T-E-R.
Yeah.
Inter.
and-
Brianna, were you
yeah,
gonna
yeah.
agree?
I just have a question.
Oh,
So,
yeah, sure.
yeah, so for the image on the right,
Yeah.
do you not have to include the carpals
The
or like
metacarpal. Ideally, a minimum of 1/3 of metacarpal.
third of the carpal? So this is fine.
This is fine.
But it's cut
I
off.
always,
Okay.
unless, no, obviously, if the patient's area of interest or the patient indicates I got injured here,
Mhm.
you got to include the whole thing, right?
Okay.
But if the injured area is here, then not really. So the
Okay.
textbook says a minimum third of the metacarpal being demonstrated. Please follow department protocol. Best practice include all of it.
Okay. No
All right.
problem.
Good question. All right. So now let's go to some actual. Alex, you got a question or a comment?
No, I was in a comment about the metacarpals also. It wasn't showing on that, so I was asking about. I was gonna ask the same question.
Got you. No worries. All right, since I got you here, Alex, what do you think is wrong with the image here? If you're speaking, you're muted, Alex.
No, I'm not. I'm just looking.
Oh, you're looking. Got you. No worries.
I don't really see anything wrong with it.
No? Let's see what who we got here. We got Regina. Regina, what you got for me?
There's not equal concavity on both sides.
Oh, let's go. Let's go with the language. Lee, what do you think? You agree or you think it's nonsense?
Yes, I agree with Regina. And then the joint space between the metacarpal bone and the distal phalanges, it's a little bit too much, the gap.
Oh, be careful. So I think you're referring to this joint. This is the metacarpophalangeal joint.
Oh yeah, metacarpal phalanges.
All right. So unless you physically pull the patient's finger apart, there's nothing you can do about it. So it might be a normal variant or a manufacturing defect, depending on how you want to look at it. But here's a joint that's not open here. You can see that's more closed than this one. See how this one's open? That one's closed. All right, nicely done with the concavity description there. I like it. How old do you think this patient is? And why would you say give an answer? Is it a child? Is it an adult? How do you know? Anybody can just put your hand up and then speak. Go ahead, Sarah. What do you got for me, Sarah?
It looks like the epiphyseal plate is very you see it a lot, so it has to be a child.
There you go. So it's not fused. This one is fused. This one's not fused. This is how we're going to make sure everybody's in on this. It's important. We're not going to just be there taking pictures. We got to know what we're looking at, right? So you're evaluating position, anatomy, presentation, disease process on every image. And if you're allowed to, go back and read the report. It's a part of your job. What did the doctor agree with what you think is wrong with the patient? This is very, very important. Let's try Wait 1 second. Let's try this one. Yasmin, what do you think is wrong with this one? Or is there something wrong with this one?
Can you repeat that, Professor?
Yasmin, I'm referring to.
Okay.
Which one? The one on the right or left?
What do you think is wrong with the one on the left?
Nothing's wrong. It looks good.
Okay. What do you think about the one on the right?
The distal,
Just Yasmin, could you turn that sound off if you could? Is it possible? Or is it something that has to?
yeah. The distal IP joint is superimposed.
Superimposed? We're going to learn this language, Yasmin. Superimposed, I guess technically is right, but
we can see it. We
can't
see the joint.
we can't see the joint. Why do you think we can't see the joint? 1 second, John. If you're not sure, that's fine.
I'm not sure.
That's fine. John, you ready? Listen, John, Yasmin. John, what you got? You had your hand up.
No pressure. I just wanted to say that because they look foreshortened, the fingers are kind of curled forward.
That's exactly right. We got the fingers curved, so they're not flat. The finger is not flat against the IR, and this is why they're for. Go ahead, Frida.
Is that a rotation there too?
Oh, I can hardly hear you. Is it
Is
my
there
thing?
Can you hear me?
Yeah, we can hear you now. Yeah.
Okay, I was saying that is there a rotation there, just slightly rotation?
I don't see it. But
Oh.
the salient thing, the most obvious thing here would be that the finger is not flat against the IR.
Yeah.
All right, Frida, I'm gonna stick with you. What aspect of the patient's hand is in contact with the IR?
You said what contact? Is it the mid carpal phalangeal?
Now, what aspect of the patient's hand is in contact with the IR?
The interior.
Anterior, or what's the other one that we use?
The palmar?
Very good. Palmar aspect. Okay, cool. So this finger is curved, Yasmin. And so as a result, the joint spaces are closed. Like you say, we can't see them. And also the phalanges and, well, not so much the metacarpal, but the phalanges are foreshortened. Remember that foreshortening occurs when the body part is misaligned with the IR. And you can see a demonstration of that. So I had one image earlier that showed proper positioning in relation to the central ray. This one shows positioning that's less than ideal and how that impacts the joint space. You can see that the central ray now cannot pass through that joint space, so it won't be demonstrated properly. All right, is that clear for everybody? Cool. This is something that's atypical, but it's possible. Patient cannot fully extend their fingers, then you would do it this way. Now, with X-ray, it's a beautiful craft because you have to learn to think on your feet and make adjustments. And you got to get some kind of image to get the diagnostic, get the answer the question that the doctor is interested in. Go ahead, Kennedy. What do you got for me?
I just want to make sure that's tape or gauze, or what is that?
Oh, you mean these white marks here?
Yeah.
Okay, these are pins. The patient has
Pins?
multiple. Well, what's the salient abnormality on these images? Kennedy, I'm gonna stick with you. What's wrong with the patient? This is not this, by the way. This is a different patient. Let's just say we're looking at this. What do you think?
Oh,
If you're not sure, that's fine.
well, I mean, here it says not extendable, but like osteoarthritis, yeah, there's like some,
Osteoarthritis?
like some of the fingers are more
Is it
brighter than others.
osteoarthritis?
One second, Frida. Let's one
I
at a
don't
time.
know.
If you're
Yeah, I
not
don't
sure,
know
that's
the
fine.
exact term.
Got you. No worries. Frida, you're saying osteoarthritis? No, there's something that's more much more obvious. Chris, you got your hand up?
I was gonna say rheumatoid arthritis, but if it's more obvious, then I'm not seeing fractures.
Yes, you are. You can
Am
see
I?
right. Yeah, you can see right there.
Okay, it's obvious fractures. Oh, okay.
Yeah, you can see right there. Right there. All these, it's all fractured bones. So someone that shows up with pins like this, they wouldn't have it in for arthritis. They would have it in for a fracture. And they're trying to stabilize these bones so they can realign. That's why they would have these. You can see the fractures here. Bam.
Yeah, so he came out from surgery recently.
Yeah. There you go. There you go. You can see it. And so this picture on the left is just for demonstration purposes. It's just possible if someone has some kind of arthritis, they can't do it for sure. Well, this one on the right has, oh, perhaps you were answering for this image on the left. I was asking about these two pictures on the right. These pins are to stabilize fractures. You can see them right there. We don't know what the X-ray looks like, but this is just for demonstration purposes. Go ahead, Lee. You got a question or comment?
Oh yeah, I have a question for like the second image and also the third image. So the distal phalanges appears more bright. What is the reason?
Because now we have, in essence, the X-rays being attenuated more in that area because the bones, well, for this one, the bones are curled up together, right? It looks like there's something that's going on in here. It doesn't look like it's because of curved finger. There might be some bits of metal. I'm not sure what's in the fifth digit. But for here, if you curve your fingers, now the area of interest will attenuate the beam more because it in essence is now a thicker structure than if it was spread out. Does that answer your question, Lee?
Yeah, but the metacarpal bones are also appear brighter. Is that so? Why the
same thing? So here, same thing. So here they're not overlapping. So if you use a fixed exposure, you'll get a more even exposure on the IR. Here they're rotated. So now we have soft tissue of the thumb being superimposed on the second and the base of the third digit. So now this area shows up white because of higher attenuation in this area.
Oh, okay. Thank you.
All right. You got it. You got it. All right. So I don't have any practice for this because this is an atypical thing, but you can see it in clinic. And then the idea is you got to think on your feet. What's the best way to get this without making the patient's injury worse?
Low mass.
Hello? Oh, that wasn't a question. It was just a rhetorical question kind of thing. All right. Here we have then going from the PA, we got a PA oblique. And there's a difference depending on which finger we're doing. So if you're doing digits, I think, did I write it on here? I don't think I did. So notice how for the little finger, third finger, and the fourth digit, we do lateral medial. For the second digit, we do medial lateral. Hopefully you guys can see the difference, right? This is the lateral side, and this is the medial side. So this is the medial aspect of the finger. That's the lateral aspect of the finger. Why? Because we want the OID to be the shortest possible to decrease magnification, give you better spatial resolution. So you can try it right now. So let's say you wanted to do an oblique of this finger, of the pointer finger, and you have the IR. Let's do this. IR like this. Now you have that large OID. But if you turn it the other way, then you have no OID, and you still get the oblique. Is that clear for everybody? We got it?
Yes.
Okay, cool.
So, Professor, for the finger, we should always do the lateral medial to, not the medial lateral, right?
For some digits. For the second digit, we do medial lateral, ideally, as long as the patient can do it.
Okay.
This is what I'm saying here. This is medial lateral. This is lateral medial. Lateral medial, lateral medial. That's a third. That's a second. I don't know which. That's a third too, it looks like. But you can do it this way too for the second digit, but this is better. Better spatial resolution.
Okay.
And less magnification.
Okay. Thank you.
You're welcome. All right. PA oblique position projection. This is what it should look like for this finger. We're not going to go through all of these, but we'll do some practice. We'll do some practice here in a little bit. What is this joint called, Jacqueline? What's this joint called?
That's the interphalangeal.
Which one?
Which finger is what you're asking?
No, just which joint? If you're unsure, that's fine.
It's the proximal.
Proximal. Okay, cool. Proximal. What about this bone here, Kennedy? I think you had a hand up. Thank you. You can just mute yourself. I think I hear your
Sorry.
dog is not happy with you at all.
That's
The
distal. I mean distal.
distal what?
Distal phalange.
Phalanx, distal phalanx.
Phalanx.
All right, that's all right. This is why we're here to practice this stuff.
Yeah, I'm sleeping.
What is this joint here called? David, what's this joint here called? Let me get my pencil.
Is it the metacarpophalangeal joint?
Nicely done. What is this part? This part of the. Well, first of all, what's this bone called? And what's this part of the bone called? So this is A.
So
Let's
that's
stick
the
with you, David.
metacarpal.
Uh-huh.
And was that a sesamoid?
Oh no, it's the same. It's a part of this bone. It's a part of A. But what's that part of A?
Is that that's not the epiphyseal, is it? No.
Not quite. I'm going to give you a clue. I'm going to stick with you, David. At the beginning of this discussion, I said to you that Jeffrey sent me an email. Oh no. One second. I said Jeffrey asked a question by email, and then I showed you what these have similar names, and all long bones have a similar name. If it's not ringing a bell, it's fine. Jacqueline's gonna give you the alley oop. Let's go, Jacqueline.
Yeah, she could
I'm
take
gonna
that.
say it's the head.
Head.
Oh.
Don't get this wrong, David. I promise you, anatomy will be on this quiz. For sure. Not even a question. Base, body, head. Sounds good, David? You got it?
Yeah, I got it now.
All
Thank
right,
you.
cool. You're welcome. That's why we're here. Dondre, you got a question?
Yeah, quick question, Professor.
Mhm.
What's concavity again?
Oh, I'm glad you asked this right now. So concave and convex refer to curvatures. Concavity, or when something is concave, that means it's curving inwards. Curving inwards. Right? That's concave. So you can see it kind of like this here. Concave. Whereas convex is curving outward.
So concavity is curving inward, and he said what was the other thing?
Convex. Convex.
Convex. That's going outward.
That's this
curving
one.
outward.
Yeah, so you could say that this part of the head is convex. And this part of the base of this proximal phalanx is concave. I could have done that better, you know. Give me 1 second. I'm going to draw the concave in blue. And the convex in red. Just so hopefully that helps. So you could say the head of this metacarpal has a convex shape, meaning it's curving outward or curving away from the structure. You could say the base of this proximal phalanx is concave, meaning it's curving towards the structure, or curving inwards. Sounds good?
Okay. Is that the same verbiage you would use for the when you're doing an oblique, how you can tell by one side is concave?
Oblique of what? I mean, of the hand?
Of a hand, yeah. You know how you could...
Yeah. We're referring to. I'm going to go back to using blue. Give me 1 second. This is what we're talking about exactly. So we can see the concavity of these long bones. So it should be equal on both sides for a PA. For oblique, not so much. You can see that it's increased here. and decreased here. I'm going to exaggerate it for demonstration purposes. Sounds good? Any other questions about this? We are almost done, believe it or not. Believe it or not, we are almost done. All right.
Professor,
Yes.
can you repeat the concavity one more time, please? I see how you drew it. It made sense, but can you just explain that in detail again?
Who was asking?
Alan.
Alan. Concave means curving inwards.
Curving inwards towards the structure. I get that. The concavity.
Convex is curving outward. All right.
So it's called concavity and convex?
Well, concavity is a derivative of the word concave.
Oh, okay.
All right.
Thank you.
You're welcome. Like brevity is a derivative of the word brief. Be short. All right. You're welcome. All right. So what do we think is wrong with this oblique? This is supposed to be oblique. What do you guys think? Let me get Garcia. What do you got, Garcia? What do you got for me?
Hey, I'm sorry, Professor, the question?
What's wrong with this one? So we've done the ideal one. It's supposed to be oblique. And now we're comparing the ideal reference image to one that's less than ideal.
Okay, so here I'm seeing flexion of the finger causing foreshortening.
Not quite. There's a more obvious thing that's wrong. If you're not sure, that's fine. Brianna wants to give you the alley-oop.
Is it overexposure?
Nah, that wouldn't be the thing. We don't care.
It looks like a PA projection of the finger, so there's no rotation.
Cool. As evidenced by what?
I
see
it's
Garrett.
like equal concavity on.
Let's go. That's what we're looking for right there. Garrett, what are you going to say? Do you agree? Is it nonsense? What do you think, Garrett? You like
same
it?
thing. Brianna nailed it.
She nailed it. She nailed it. So, Garcia, you can see that we have an exaggerated concavity on this side for an oblique, as it should be. And on this one, it's equal. That means it's not oblique enough. Sounds good? In the notes for each PowerPoint slide, by the way, each of these, I have what's wrong and what should be fixed. Again, do not look at it while I'm asking you, please. I want you to think about this. All right, so let's try this one. First of all, what is a salient abnormality? What do you got for me, Hui Ming? What do you got for me? Do you see anything wrong, any abnormal presentation?
The finger is not straight.
Oh, no. Tell me abnormality. Is there anything wrong with the patient? Not the projection, not analysis right now. Is there any injury that you can see?
Any injuries?
Yeah.
Not really.
That's all right. I'm going to come right back to you, Wei Ming, for the analysis. But let me see if Conlan has the answer for it, if there's an injury that you can see.
I think I see reduced bone density.
This is good. Let me see. Who else had their hand up? Roxanne, what you got?
It looks like they have a fracture in the physial plate.
Physial plate? Oh, okay. What part of the bone are we talking about? So you can describe to me as I'm from Mars, so you can tell me.
It looks like it's a fracture on the head part of the proximal pharynx.
Here?
Right there, yeah.
Right here?
Yes.
I see. Not quite. I was referring to this one. You see that?
Yeah, I do, but it looks real prominent on this one.
I see. Could be. So this is the head for sure, but this is Roxanne, were you going to say that? I'm not sure.
Yeah, I mean the head part. Well, I was looking at the upper portion, but
Got you. All right. So there's the salient abnormality here. All right. So Hui Ming, what do you think is wrong with this image? Now it's your turn for analysis practice.
From the compared with the left side of the image, this one is little bit not flat enough of the finger and then it should be a little bit on wait a second. It's the left side. It should be medial lateral view, but is not relocated that in the right positions?
Could be. Could be. There's another reason here. Another thing that's obvious, I think. Notice how the joint spaces are closed for this one. So here it's open.
Well,
For this one,
but the middle between the middle phalange and then the proximal phalanx is not also open. It's not open too compared with the left one.
yeah,
The left one doesn't open.
this one is well. Let's say it's more closed, is what we should say. You can see this overlap here. We don't want that.
Oh, this is overlap.
Yeah. See
Yes.
how the
Oh,
base
okay.
of that one overlaps with the head,
Okay. Okay.
and the finger is flexed.
Yes.
We don't want that.
Yeah.
Now, it could be as a consequence of this injury, and the patient can't do it. I do not suggest you slap the patient on their hand with a ruler and say, straighten your finger, because that's gonna make it bad, right? It could
Yeah,
be
but
they can't do it.
just compare with the image.
That's exactly right.
really- Yes.
So that what would fix this is a straining of the finger.
If the patient is able to do it.
Okay.
If the patient is able to do it, they might be in pain from whatever this injury is right here. All right, what about this one?
Professor,
Raul?
I
go
did
ahead.
one of the hand X-ray. Then the patient was in terrible pain, so she couldn't move her finger, and we had to take the picture like it was.
Yeah, that's
So,
how it is. That's how it is. Jeff, you got a question?
Yeah, the previous slide, just to make sure, there's a fracture at the head and the base, or
I
is
don't
it
see
just the
I don't
base?
see one at the head. I see one at the
Oh.
base.
Okay, got you.
I don't see one at the head. There is some
That's not one right there, right where you point at.
by my untrained eyes, no. That doesn't mean
Oh.
the radiologist wouldn't classify it as some kind of abnormality.
Okay.
The obvious one that I can see is this one.
Okay, got you.
All right. Remember, this
Alright.
is not a pathology class. We're just having general discussion. So it
Oh,
could
okay.
be that there's some abnormality here. However, a fracture is strictly defined as a discontinuity in bone cortex. So this is the cortex of the bone. And if you draw a line, you can see, oh, it's broken. And it continues here.
Okay, got you.
All right.
Thanks.
So strictly speaking, that does not mean we've exhausted all the presentations for abnormalities on this image. All right. Okay. But please continue to look at these critically. So it could be that there's decreased bone density. Could be all that stuff. I don't think so in my opinion, but I'm not a radiologist. I've just been looking for a long time, and there could be something else, which means it is your job to speak with your teamwork, your team members, and if possible, the radiologist, and at a minimum, read the report to see what they say. So if you suspect something's wrong, it's okay to look at the report. You will not get in trouble. If you're looking at somebody else's report that has no business, like a star or a movie star or somebody, or even your mom's or your friends, that's a problem. If you just did a patient for educational purposes, you can absolutely read the report. All right. So what about this one here? Raul, I think you're up.
To me, it just looks like the metacarpals are all superimposed on each other.
Metacarpals. So we don't care so much about the metacarpals. We're doing the fingers. But that is impacted by the reason why this is less than ideal. Raul, would you like to give it another shot? 1 second, Regina.
I'm not sure, Professor.
That's all right. Regina, what you got?
There is not enough distance between the fingers.
Excellent. Excellent. So you can see there's separation here. There's no soft tissue overlap at all. So we've ideally properly separated the fingers. You should do it for all of them. You're doing this one or this one, you pull those back. And for this one, you do it like this. For this, you do it like that. All right? You can't do it like this because then you're going to have this presentation. All right. And it continues with some more practice, but you can do it on your own time. I have the explanations in the PowerPoint, but we will move now to the lateral, which will be the last thing before we do the thumb. We're doing great on time here. So the lateral is pretty straightforward. The important thing is to move the other fingers out of the way as much as possible. Now, how would you describe, wait, 1 second. Layla, how would you describe this projection? Is it medial, lateral, lateral, medial, PA, AP? What do you think? This one here.
It looks lateral medial. No. I think it's lateral medial, medial lateral. I'm not sure.
No, say it with gusto. Pick one. Which aspect of the hand is this, lateral or medial? Think anatomical position.
That
sorry?
is lateral.
Good. So which aspect of the finger is this one?
Medial.
Mm-mm.
So okay, so the pinky is lateral.
The pinky itself is medial for sure. But
Okay.
if you look at the pinky by itself in an anatomical position, this side is the medial side. This side is the lateral side. So everything can be broken down to lateral side and medial side. If you look at the hand itself, the thumb is on the lateral side for sure, right? And the little finger is on the medial side for sure. But then if you just look at each finger has a medial side and a lateral side. Medial side is here, lateral side is here. So
Okay.
always look at it. Let's say this, okay, look at it this way. Imagine this person unfortunately had just one finger. And their one finger is what is this? 1, 2, 3. 1, 2, 3. Third digit. The ring finger. All they had is a ring finger. Which aspect of the finger is this one, you think?
The one that's pointing up. Which aspect is pointing up?
Yeah, this I'm touching right now. Pointing up.
That's
That's not
the-
touching the IR.
That's the medial aspect.
Mm-mm.
No.
Put the ring finger, put the ring finger by your side in the anatomical position. Do it right now, please.
Okay.
You have it pointing down?
Yeah.
Now put your left hand on the lateral side. Put it up to
Okay.
the camera. Let me see.
Like this is how I have it. Does that make sense?
Yeah. So put your I got it. I see it. And put your left finger, no, one of your fingers on the lateral side of that ring finger. I can't see your thing. Move your hand.
Like that?
You have it.
The lateral side.
No. So this is my finger. Oh, wait a second. Let me see how else I can explain this. Okay, I got it. Let me stop sharing for a second. This is actually important. So on the registry type material, you can be tricked easily. So let's use this. Let's use this one. And okay, beautiful. All right. Can you see this image here?
Yeah.
All right, beautiful. And then let me do this. Let's minimize that a little bit. Make that larger. Okay, beautiful. So this should be nice and large on your screen now. All right. So this skeleton, Layla, and everybody else who might still be struggling with this, which is fine, by the way, is in the anatomical position, right? So it's clear that this thumb, the entire thumb, is on the lateral side, and the entire middle finger, or little finger, I'm sorry, is on the medial side. Is that clear so far, Layla?
Yes.
Cool. So then, if we just take one finger, each of these fingers will have a lateral aspect and a medial aspect. That's all that is, right? So if we look at this side is going to be the medial aspect of the little finger. I'm going to put in red here. This side will be on the lateral aspect because it's towards the side. Same thing for this finger, and this finger, and this finger, and this finger. And I put the medial aspect in blue because it's closer to the midline. That's why they refer to the side that's closer to the body as in the anatomical position as being medial. The side that's away from the body in the anatomical position as lateral. Does that help you, Leila?
Yeah, that makes sense. It's just from the angle that it was shown before, I couldn't really tell which was the medial and lateral side.
Got you. So then if you move, so then if I'm using my right hand, right hand like this, you can see my hand, right? Actually, let me use my left
Your
hand.
name is covering it. Yeah.
Can you see it?
Yeah.
Okay. So this finger would have the medial side in the anatomical position. So it doesn't matter how I put it. Now the medial side is going to be down. So you're just going to follow. Oh, here's a cheat. Give me a second to think of a cheat way to think of this. Give me a second. The side closer to the thumb is going to be the lateral side. How about that? For the digits. And the side that's pointing away from the thumb is going to be the medial side. Does that help
Okay.
you?
That makes sense.
All
Yeah.
right.
Thank you.
You're welcome. Slideshow. All right. So this is a lateral medial projection. Same for this, and this is different. This is medial lateral projection. Pretty self-explanatory. It's not going to be dissimilar to the lateral for the hand, except we don't center at the MCP, we center at the PIP, proximal interphalangeal joint. Students in practice, what do we think about this this position here? Let me get Ibrahima. In the interest of time, Alex, what do you got for me? What do you think of this projection here? Is it lateral, not lateral? What do you think?
It's lateral.
This one?
Yes.
You like it?
Not enough space between the joints, between the head of the phalanx and the base of the mid phalanx.
Kind of, but there's something else that's happening there. These are actually condyles, by the way. There's a groove in between. These are not superimposed. And it looks rotated from the lateral. You see it? See how their heads are superimposed here? And here they're not, they're separated. Joint space is also way more closed than this one. Can you see that, Alex?
Yes. Yes.
Okay, cool. One more practice before we go to the thumb. The rest you can do in your own time. What do we think about this one here? Let me get Kazi. What do you think, Kazi?
It's not properly aligned on the image receptor.
Sure, that's one way to say it, but what else could have been done?
I don't know, sorry.
That's okay. Anybody wants to give it a shot? Go ahead, Phoebe.
I feel like there's a lot going on. Like you should have like proper collimation, and the fingers shouldn't really be doing all that. You're trying to get one finger, and they're all in there.
Oh, there you go. That's good stuff right there, right? So separate the fingers more so we can isolate the finger that we're trying to image. And there's some amount of rotation. You can see that the condyles of the head of this proximal phalanx, they're not superimposed. All right. For the thumb, we like to do it this way. It's an AP projection because it's entering the anterior aspect and exiting the posterior aspect of the hand. It's going this way. And from the anatomical position, it's AP projection because we're entering the anterior aspect and exiting the back of the thumb. We prefer this way to decrease OID. It can be done this way also. PA for patients who are unable to twist their elbow like this. This is not comfortable for everybody, but it can be done this way. But this is the way that we prefer to do it, so we get better spatial resolution as a consequence of decreased OID and less magnification. We do it this way. All right. So this is how we do it. You already know the anatomy. And we center at the first MCP, meaning the MCP of the first joint. That's all that is. Because this doesn't have a proximal interphalangeal joint. It just has a metacarpophalangeal and an interphalangeal. So you center right here at the MCP. Right? And this is where we center. And this is what it looks like. At this point, you should see the pattern. This is all repetitive. As long as you know where you're centering, for the hand, it's always going to be an MCP. For the fingers, it's going to be the proximal interphalangeal, that if you're doing the second through fifth. For the first, it's going to be the MCP of the thumb. Okay. Let's practice looking at some images here. What do you guys think about this one? Let me see. What do you see? Dongwan, what do you think? Oh no, we lost him. In the interest of time, Kennedy, what do you think?
For what?
We're doing AP thumb analysis practice.
I would say that there's some superimposition on the right image.
Of which bones?
I want to say the second and third digit. You can see them more.
Yeah, so these bones are superimposed. We don't want that, right?
Yeah.
We don't want that at all. This is why we try to do it like this, to separate those fingers. The metacarpals second through fifth from the first, or like this. So here they're superimposed. We don't want that. Let's try one more. What about this one? Let me see. Kazi, what do you think?
In the right picture, Professor?
The one on the left is always the reference picture.
Okay. I think this is good.
This one, you think so? Anybody disagrees?
The space.
Yes, I disagree.
Go ahead, Frida, what do you say?
Oh, Professor, I think the distal part is like there's no space.
Sure, that's one way to say it. Go ahead, Frida.
Yeah, I think the distal part is foreshortened.
Foreshortened, right? So the fingers are flexed. All right, so it's actually extended in this case, but it doesn't matter. It's foreshortened is the way that we would say it. It's foreshortened.
Okay.
All right, and the rest of it you can do on your own time. I want to get to some questions here. The PA oblique projection. Okay, so remember when we did the hand, and I said that the thumb is oblique, right? Notice that the thumb is oblique just because of how our body is. Well, when you're doing an oblique thumb, you're basically doing a hand position to get an oblique PA oblique thumb. So there's no change of the hand, except you're centering now on the thumb, the MCP of the first digit. And that's different than if we're doing a lateral. For the lateral, you have to push your fingers up or to raise the fingers up with a sponge so you can then put the thumb in the lateral position. For the oblique, it's like positioning for a hand, and that gives you a naturally positioned PA oblique thumb. Again, for the lateral, you're just bending the fingers up. That's one way to do it. Or you put the fingers on a sponge, like a little sponge like this, to get the thumb in its true lateral position. All right, is that clear? All right, when you go to school, you can just go in the lab and play around with the machine just to practice this stuff too. Print this PowerPoint out, or at least have it on your phone or tablet or something. Go ahead, Alan, you got a question?
Yeah, for the thumb, right? There's never a PA, correct? There's always an AP because you have to turn your hand the way it is on that picture.
No, I think I showed that image. Maybe I think I did. where you can do a AP or you can do PA.
Oh, okay.
All right.
Thank you.
You're welcome.
Professor, I'm sorry. For the AP, for the thumb, are you going to turn the whole hand? Because when the patient turns just the wrist, I don't think you get a proper position. So you're going to turn your whole hand
For
so
the
that,
AP,
yeah.
you're gonna do it just like this. The
Okay.
whole hand,
So,
just like this. Hand,
okay.
elbow, the whole thing. But not everybody can do this. It's really if you try it right now, you'll see how
Yeah,
uncomfortable it
because
is.
I feel pain at my elbow.
Got you.
Mm-hmm.
Get that checked out. I'm joking.
Okay.
The you shouldn't. Well, it's possible, I guess. Maybe you play tennis or something. But if it's painful for you, imagine somebody who has a suspected injury. You can see how that's a problem.
Yeah.
Right? I want to get to these special views here. So the AP axial projection, modified Roberts method, where we angle 15 degrees proximal, is to look for a Bennett's fracture. For Bennett's fracture, make sure you know this. For Bennett's fracture.
Question. Which one is the most common fracture in the hand? Is it the Bennett's?
I don't know if I've ever heard any of them listed as most common
Or
fracture.
the boxer, I think. I'm not sure.
I don't know. Maybe the boxes? I don't know. Maybe. I've never heard anyone describe any of the fractures as more common than the other. I guess it would depend on where you are and what you're doing. All right. Now this is for, again, the Bennett's fracture.
Professor,
So is the Roberts method for the Bennett's fracture?
Wait 1 second. I heard another voice before yours. Please go ahead. Female voice. Who was the lady?
Yeah, it was me. Sorry, I didn't raise my hand. I just want to, could you please tell me what is the page number of this slide? Because I was trying to look for it, but I don't see it.
Got you. I'll answer it in just a second. And then the other person who had their started speaking?
No, I just wanted to make sure it's called the modified Roberts method.
Yeah.
And this is when we're looking for the Bennett's fracture.
Yeah. Yeah. To answer your question, Lee, the PowerPoint I uploaded, I compiled this PowerPoint from 3 different books because some of the books don't have all the information. But I went by what I think you need to know, not just for clinic, but for the ART registry. Alrighty, because sometimes the books don't always have all the best images, and they don't always have all the images related to this. Alrighty. If I get access to the course, then we'll narrow it down to which book we're using and which chapter is going for which material, and then I'll make sure it's posted on Canvas. Alrighty. All right. The other special and that's what it looks like, by the way. So if you notice, when we do an AP thumb, let's go to the AP. Well, this one's pretty clear right now. This one's pretty clear. But let's look, but it's not always clear. The base of the thumb is not always clear. But when we do this method, now we can see the joint space. This is not even that great to be fair. We can see the entire joint space because we're angling proximal to the first metacarpal. Okay. The other one is this one, the PA stress folio method. What's this one for? It's for ulnar collateral ligament. Now, you would think ulnar ligament would have to do the ulnar bone. You're thinking, where the juice is the ulnar bone? It's not even on that side. This is the radius. Well, there's a ligament called the ulnar collateral ligament. That's right here. And that's what this projection is for. Not on the registry, but it's good that you're exposed to it here, so it won't be completely unfamiliar to you. But regardless, this and other projections you will see in clinic, there's going to be a book, some reference that you can follow. All right, what's this one for? Torn ulnar collateral ligament. Incidentally, they would not just rely on x-rays for this. I promise you. They would do MRI as an adjunct. This would be just your starter. If you're wondering, this is just a tape that they use to separate the hands, the roller tape, as we technologists like to improvise.
Professor,
Yeah,
is the carpal tunnel syndrome gonna be part of this as well or no?
that's for the wrist.
Oh, wrist. Okay. Gotcha.
Go ahead, Kennedy.
When you're putting tape or gauze, do you have to make adjustments to your technique?
No, because it's not in the area of interest.
Oh,
Oh, you mean like this or this?
um, not specifically for this one, but like I remember in clinical they had to put tape around the patient's hand, not hand, fingers, so that it doesn't move.
No, you don't have to adjust technique. Tape unless you're using a big roll of tape, which hopefully not, it's not going to impact your exposure. We are at the end of class. Here's what I suggest. I'll stick around for 10 minutes for those who have questions, but those who would like to log off, you're free to do so. To continue on with your question, Kennedy, you're using exposures that material that's going to be radiolucent, so it will not impact your exposure setting. Okay.
Okay.
All right.
Because I mean they added technique for that.
Oh, okay. Well, it might be something that they choose to do, but you don't have to.
Okay.
Go with what they do in clinic. All right, but remember we can now window and change the appearance of the image on the screen. So as long as you get something, the radiologist or yourself can adjust the window settings of the image. How you should study this stuff is go through the PowerPoint like I just did. Take your time, go through it. Looks like a lot, but it's not really. The rest of these are just questions, and the answers are on the next screen. One second, Lee. So when you go through this, there's some practice questions on here. The answers are, try to answer them without looking for the answer, but the answers are on the next PowerPoint, right? And then there's some critique questions and so on. It's just practice stuff. Going through, I can delete some of this actually. This doesn't need to be here. And then there's some summary slides of the lateral hand, what you should have on it in a summary. But in the notes of some of these, I have a detailed description of positioning, image analysis, essential array and collimation, and some KB stuff as well. All right. So if you see an image like this, try to label it. It says label on here. Take the time to practice labeling this stuff. I'll get to you 1 second, Lee. Do the same thing for this. So unless it's a specific question, it's a labeling stuff, right? Then it says critique error, do the same thing. And there's obviously a fracture here, you can see that. And labeling, so it's not a lot of stuff here. It looks like a lot of stuff, but not really. And that's the end of it. So about 2/3 of it is content. No, half of it is content. The next half is just practice and image analysis and practice questions and so on. Go ahead, Lee, you got a question, comment?
Yes. So for the PowerPoint, you have notes under the images, right? Would you happen to know how to view the images with the notes on the iPad?
On the iPad?
Yeah, because when I open the file on my iPad, I'm not able to see the notes that you made for those images.
Got you. Are you on your iPad right now?
Yes.
All right, 1 second. Do you mind sharing your screen?
Oh, I don't think I can share my screen because I'm using okay, I have 2 iPads right now. I have one iPad for the screen and then another one to take notes. So
got you. At the end of each slide, take it out of presentation mode or full screen mode. You should see a section that says
do I download the Microsoft Word app on my iPad in order to view those notes, or because I'm actually using the GoodNotes app to take notes and view the slide, so I'm not sure how it works.
There are multiple ways you can do it. You can, first of all, you have PowerPoint for free from the school. I think I sent instructions on that. Yeah, so I think I sent the step-by-step instructions how to download it for free. You have PowerPoint, Word, and all that. You can, I think, put up 6 devices. If you don't want to do that, you can just click Notes, and you should see it appear when you have it on your iPad. The other way is to just drag and drop it on in your Google account, and it will show up as a Google Slides.
Oh, okay. So I'm just and then utilize the Google thing.
You can if you don't
Yeah,
want to,
yeah.
but
I'm gonna try on my own and see how it works. Thank
I
you.
think I think everybody should download the PowerPoint. It's free and you have it for life as long as you have the account,
Oh,
the email. So why
on
would you not?
Microsoft.
All right. Let's go in order of Frida, then Layla, then Don Juan.
Yeah, sure. Hi, Professor. I don't see all my slides on the PowerPoint, but Alan is helping me do it. So when I get it, I'll let you know.
Okay.
All right. Thank you.
Layla, what you got? Oh no, are you speaking? Your hand is up. Do you have a question or comment?
Yes, I have a question.
Of course.
Sorry, I think my internet is acting up, but I just wanted to know if you could quickly explain why the joints for the first carpometacarpal joint and the second to fifth are different. Like, is it because of the sesamoid bone? If that would make sense.
1 second. So if we're looking at, let's see if I could get this to go up really fast. All right, so we're looking at the PA hand, probably. Is that what it is?
I just went all the way to the top where it showed the different joints of the wrist. I think it's the 7th slide.
7th slide. So this one. Okay. Let me move this down. All right. I'm saying your question once more. I'm sorry. I had to have it up. Why are they different? Oh, different types of joints? Is that what it is? Oh no. Did we lose her? Oh no.
Hello?
Yeah, there you go.
Sorry, I think it's the weather, but
Yeah,
yeah,
no,
so seeing that says the first metacarpal joint is a saddle or cellar joint, but the second through fifth are plane and gliding. I just want to know what the difference was. Like
Oh,
not with the joints, but why the joints are different.
fortunately for you, I anticipated this question. And so I have put in here in the notes the descriptions, but I'll still say it. So you can see it right here. And once you download the PowerPoint, you can see it. It's pronounced, I actually put the pronunciation here, ginglymus. So weird. Ginglymus is a hinge type joint. So if you look at how your fingers move like a hinge of a door, that's what a ginglymus joint does, right? A condylite joint, also known as ellipsoid, it has, what do you call it, movement in 2 planes. So you can do this or you can do this. Oh, I'm looking at that, but you can do this and you can do this. There's 2 planes. Sounds good? But you can't do that with your interphalangeal joints. You can only move like a hinge of a joint. If you do this with your interphalangeal joint, something's wrong. Get that checked out. You should only be able to do this. That's why it's called a ginglymus joint. And a gliding joint, well, it's only sliding movement, like the name says. Sounds good, Layla?
No, yeah, I understand the difference between each joint and like their range of motion. I was just more wondering
We should
why.
go, right?
1 second,
Can you hear me?
Frida. No, I can hear you. Go ahead.
I was just wondering why the first
I'm
carpometacarpal
sorry.
and the second through fifth carpometacarpal joints are different. Like, why are they different types of joints?
Okay, so why these are different from these?
No, the carpometacarpal joints.
Why these?
Why the first one is different from 2 through 5.
Oh, I see. Why these? Oh, okay. Oh, I see what's happening. Okay. So if you notice, your thumb has the most flexibility. So it's by grand design or a big bang or whatever you want to call it. This is just how it is. And notice that the carpal bones, even though as you learn next week, if you haven't learned this already, there's a proximal row and a distal row. It's not really uniform like in the rows of a church. This is just how it is. So there are all kinds of bones. If you notice, for example, this bone here, the capit, no, this is the scaphoid lunator. It's not even drawn properly. But this bone here, it's like the hamate, I think. I think it's a hamate. It's not even drawn properly, but it's fine. This bone here is forming a joint between the bases of the 4th and 5th. And this one's only the 3rd. So it's not really uniform. It's just by grand design. Just as how it is.
Okay.
All right?
Okay.
All right, cool. You're welcome. Don Juan, go ahead.
Sorry.
Oh, no, you're speaking, but you're muted.
Oh yeah.
Cardinal zooms in. What do you got?
I thought I heard that you asked me a question, but I wasn't here. I had a little situation at work and I had to drive quick and yeah.
That's all right.
I apologize, yeah.
That's okay. Thought you had a question. Oh, no worries. Wei Ming got a question?
Yes, I still confused about the MCP, CMC. About a joint. How you name it? I didn't. When you asked Phoebe, and then you said, "How come you don't know?" And then I also the one who's confused and don't know how
Oh,
to.
so two of you are still unsure. That's all right. Hopefully Phoebe's still here. We can talk about it a little bit more. So we can take a look, right? So I think I said at the time, I don't remember what I said, but I'll try to say it again. The joints are formed or named for the bones that, one second. The bones that are involved. So the carpal metacarpal joint involves the carpal bone plus the metacarpal bone. Hence, it's called the CMC joint. Carpal.
Oh.
And so the MCP would involve the metacarpal plus the phalanges. So it's a metacarpal phalangeal joint.
Oh.
And the interphalangeal, inter just means between. So these bones are the same. So how do we differentiate between them? We say one is proximal, one's distal. So one's proximal interphalangeal and one's distal interphalangeal. Sounds good?
Yes. Right now I got it. I mean, okay. Oh, that's what you mean. Okay. So if the can you test me a little bit and then I make sure that I understand?
Oh, I can do one better. You ready?
Yeah, please.
Oh, you're gonna be so happy with this. I promise you. I promise you.
I just want to make sure that I understand what you talk.
I know.
And then I want to.
I know. I am being a little facetious here, but I'm gonna show you how. I see you, Dandre. I'm going to show you. I still don't have access to the thing, but it's okay. So what we will do, if you go to announcements, right?
Announcement.
And you see what it says in preparation for procedures class. Review the following material and check it out.
Oh, okay.
You click
Got
that,
it.
pops right up.
Yeah, I opened it before.
It pops right up. Here's another one. I put two of them. This one is what you're familiar with. Oh, click that. You play the whole game.
Okay, got it.
All
If
right.
I have any question, I will email you.
Yep, you got it.
Thank you very much. Appreciate it.
You're welcome. Dandre, what do you got for me?
Is there gonna be a tutoring session at 8 tonight or?
Yeah.
Okay, and
every Monday.
Oh, every Monday, and then you're gonna submit the grades for physics tomorrow or?
As soon as I get them, I put them in. I haven't gotten them yet.
All right, no problem.
I haven't gotten them yet. I think I put in rad protection. Yeah, rad protection's already in. The as soon as I get them, I put them in. I don't delay.
Okay.
My Wi-Fi turned off. I tried to join from my phone, whereas but you try to go over the slides. Okay. Actually, you know what? I can stop recording now. We don't need this part of the thing. 1 second. So again, class is over. So I'm only staying for those who have questions.